Bismillah ar-Rahman ar-Rahim. Today we will be a final revision session for September 2020 candidate as a fast revision and to the point, inshallah. Before we start, I would like to thank Dr. Ghada Badrak for collecting all these mentors in one course. Actually, it's a great effort from her to collect all these mentors. The other thing, I should thank Dr. Asif. I hope that I'm pronouncing the name right in the right way. He did a lot of effort in organizing and publishing these links and these lectures. Hoping for you all the best. Let's start our sessions.
It is recording, Dr. Hany?
Yeah, I start the recording already, Dr. Sana. This is the final revision, or it will be the exam tips and tricks. Bismillah ar-Rahman ar-Rahim. The MRCG Part 2 Crash Course, the final revision for September 2020, and exam tips and tricks. A lot of exam questions, inshallah, will come from today's session. From my heart and all the mentors' heart, wishing for you all the best and for passing this exam. Already time is narrow. You need to revise, question more, answers. A lot of questions, go back for the evidence. There is no time to lose in reading more detail. Just focus on questions in the last 10 days. Revise the GTG chart, revise the important point for the exam. So you will be in the top 20, inshallah. The first dictate I want to clear, because one of you posted a question on the group or in the public groups, and I was very happy to discuss this question today. So I will start by the preterm labor tricks and polit. It will be a shots for the exam. So the preterm labor in polit, what to do, when to do, what to give. So first of all, what will be the diagnosis or how to diagnose a PPROM or a premature pre-labor rupture of membrane? The first thing in the exam, to take a history and ask and do perspiculum examination. So the first thing, or the first, if a woman came for you with a history of leaking, you will take a history and you will put a sterile speculum to confirm what? To confirm there is pooling or no by your naked eye, by your cascospeculum. So this is a question to confirm that the woman is right and she gives you the actual history. So you will put a sterile cascospeculum and you will find a liquor in the vagina, so positive pooling. You will offer a treatment. What will be the treatment? I will tell you. Negative pooling, you didn't confirm. There is no pool. There is no liquor in the posterior vaginal fornix by your eye, by the cascospeculum or the perspiculum examination. So you will consider to do the insulin growth factor binding protein A or the amniosure, which is the placental immunoglobulin or alpha globulin. If this test is positive, treat the patient, as I will tell you now. If not negative, discharge the woman. So to diagnose preterm pre-labor rupture of membrane, first history and speculum examination. If you find pooling, treat the woman. Offer antibiotic, offer erythromycin 250 4 times a day for 10 days. If you didn't find negative pooling, so consider the test, which is the amniosure or the insulin growth factor binding protein 1. Positive, treat as rupture of membrane or PROM. Negative, discharge. So this is the first flow chart for the exam. What is the test? It is the insulin-like growth factor binding protein 1, it's present in a higher concentration in the amniotic fluid. If you cannot find the pool, so negative pooling, I will do this test, or the amniosure, which is the placental alpha microglobulin 1. Is this point clear before I move? So this is the first trick.
Yes.
Yes, sir.
Okay. So this is the first trick for the exam. The second trick, the woman came in a preterm labor with intact membrane. Again, I will do what? History and per speculum examination. So don't forget this. This is the first RSOG trick in PPROM or in intact membrane. Take a history per speculum examination. Positive or negative, I will see. If the patient less than 30 weeks, in the exam question, he will tell you the patient is 29 weeks. So he mean to mention 29. Why? To give you a hint that the patient is less than 30 weeks. So a history, per speculum examination, and positive finding, and the patient is less than 30 weeks, treat the woman as a preterm labor. Advise treatment. So this is the second trick for the exam. A woman with a history of labor pain and intact membrane, diagnosis by history and per speculum examination. The woman less than 30 weeks, advise a treatment. More than 30 weeks, what I will do, I will go for ultrasound, transvaginal ultrasound. So less than 30 weeks, he will mention in the exam, 28 weeks. So give a treatment. What will be the treatment? It will be glycolysis, dexamethasone, magnesium sulfate, according to the clinical scenario in the question. So less than 30 weeks, advised treatment. More than 30 weeks, so the first step to do a TVS, a transvaginal ultrasound. What will be the finding? Less than or equal to 15 millimeter, 1.5 centimeter, so you will diagnose that it is preterm labor and treat. So if he tells you that the cervical length by transvaginal ultrasound is 15 or less, so this is a PTL, a preterm labor. I will offer the treatment. What will be the treatment? I will give you within a second. If it is more than 15 millimeters, so the woman is not in a preterm labor, discharge here or think another diagnosis. If the ultrasound is not available, he will tell you in the exam, no transvaginal ultrasound is available. So you will think about fetal FIBRONECTIN test. If the transvaginal ultrasound is not available, you will consider doing the fetal FIBRONECTIN test. If it is positive, treat the woman as a preterm labor. If it is negative, discharge the woman and tell her that you are not in a preterm labor. And the cat value is 50, fetal FIBRONECTIN. If you find it 50 or low or more than 50. All this you will find in the guideline, but I am giving you the RSOG tricks. So if the woman came for you with a history of preterm labor, you will start by the cascospiculum. The cascospiculum finding, so cervical changes. So there is cervical changes, and the woman is less than 30 weeks, I will treat her as a preterm labor. More than 30 weeks, I will consider or I will do transvaginal ultrasound. If the cervix more than 15 millimeter, so it is not a preterm labor. If the cervix is 15 millimeter or less, it is a preterm labor, and I will treat as a preterm labor. If the transvaginal ultrasound is not available, again, you don't have a transvaginal ultrasound in your unit. It is not available in the midnight. You cannot have access for it. He will tell you in the question like this. So he is pushing you to choose fetal FIBRONECTIN. Positive, treat the woman as a preterm labor. Negative, discharge the woman. She is not in a preterm labor. Clear? I will move. It's fine?
Yes,
Clear,
sir.
sir.
Okay. So let's go for the treatment. What will be the treatment? And what will be the other tricks for the exam? What is the fetal FIBRONECTIN? Why we are doing the fetal fibronectin? Simply, the fetal fibronectin is the glue matter or the fibers connecting the fetal membrane with the maternal membrane. The fetal side here. This is the fetal side and this is the maternal side. And the fetal fibronectin is here. It's the glue or the fiber connecting both the fetal side and the maternal side. If the woman have preterm labor, it will appear here and it will give you a positive test. That's why I am thinking about it. If the woman have a history and cervical changes, it will appear in your test. Okay? This is the fetal fibronectin. What will be the treatment? What will be the tricks for the exam? I have two options to give prophylactic vaginal progesterone or prophylactic circulage. What to do and when to do. When to think about vaginal progesterone only, when to think to do cervical circulage. Offer that choice, either this or this, for vaginal progesterone or to do a circulage. For a woman who have a history plus short cervix. So, if the woman have a history, she have a preterm labor before, a woman have a spontaneous preterm labor or mid-trimesteric loss between 16 and 34 weeks, and the transvaginal ultrasound is less than 25. So, I will offer this woman the choice between vaginal progesterone or cervical circulage. If what? If she have a history or she have a cervical length less than 25 millimeters. I will do vaginal progesterone only. It is not oral or rectal. Vaginal progesterone for a woman who have either this or this. So, in the exam question, he will tell you that the woman have accidental ultrasound scan show that she is less than 25 millimeters. So, a history of spontaneous preterm labor or loss, or the woman have accidental ultrasound less than 25, or you will go for the third scenario. So the first scenario, I will offer the woman the choice between circulage or vaginal progesterone if she have both this and this. If the woman have one only of these, a history of preterm or accidental ultrasound now, so I will offer her only vaginal progesterone. This is the second trick in the preterm labor. The third one, to think about circulage. I will repeat it again. This slide is very important.
Yeah, please.
I will repeat it again. This slide is very important. And by the end, I will repeat and repeat and repeat. I am staying with you today till all of you are satisfied. I will not close the session today. I have a target, and I hope I will finish the target. So, when to think about cervical circulage? If the woman have a transvaginal ultrasound, and this scan shows that is less than 25, and who have a history of rupture of membrane, preterm, pre-labor rupture of membrane, or cervical injury, like cervical circulage, or a history of cervical trauma, like she have a history of leads. So I need two criteria to think about circulage. A transvaginal ultrasound with a history or had a preterm, pre-labor rupture of membrane, on a previous pregnancy, or a history of cervical trauma. Again, to offer that choice, I should have both together. History of preterm labor in the previous pregnancy or mid-transferic abortion, and the scan now. So I will offer the woman to choose. It's her option. She will have the counseling. to choose between what? Between vaginal progesterone and cervical circulation. If a woman came to you with a history of preterm labor and her scan now post and the scan now shows a low cervix less than 25, so I will offer here to choose between either vaginal progesterone or cervical circulation. If she have only one of these, history of preterm labor or the cervical length now. So in the exam question, he told you a woman accidental finding cervical length is less than 25. So the answer will be only vaginal progesterone. Or the history in the previous pregnancy, the woman have a loss only, and the scan now is fine. So the answer will be only vaginal progesterone. So you will give vaginal progesterone for a woman who have either a history or accidental cervical length shown. If the woman have a scan now less than 25, accidental finding, and she have a history of PPROM or leads, here I will think to tell her to do circulation. Did I make everything clear? I made it clear or still need to be revised? This will be the tricks for the exam. The woman have both offers a choice. She's the one to choose. The woman have either preterm labor or accidental cervical length, so the answer will be vaginal progesterone. Circulage only if the woman have a vaginal ultrasound now less than 25 and she have a history of PPROM in the last pregnancy, in the previous pregnancy, or a history of cervical trauma, like she have a history of leads. So I will offer here circulage. When to offer vaginal progesterone, when to offer circulage, when to give the woman the choice is a very important point for the exam. Clear? I will move to another trick.
Yes, sir.
Okay.
Sir, just a small point. Sir, everywhere it is written less than 25. It should be less than and equal to 25 mm.
Less than.
It should be less than and equal to both.
If more than 25, so it's not a preterm labor. Less than or equal, no problem, yes.
Less than or equal to.
Yes. Okay?
Okay, sir.
So when to choose to offer the choice if the woman have both history of preterm labor and the scan now is less than 25. When to do vaginal progesterone only if the woman have history or the scan is less than 25 now. When to do cervical circulage if the woman have a scan now and she have either this or this. In the question, he will push you to choose the right answer. So now we are fine. Does this make sense? We can move?
Can I ask a question?
Yes, sir.
Yes, sir.
Okay. Please
Sorry
keep
for
the
the
question to the pause. If you want to ask a question about the topic, keep it in the pause. I will pause after each topic. Okay?
Okay.
Okay. So this is the tricks to offer what? Offer vaginal progesterone or offer prophylactic circulage. The rescue circulage, when to offer? You will offer rescue circulage if the criteria is met. So don't offer rescue circulage or rescue cervical circulage to a woman with an infection or a bleeding or she have a uterine contraction. So exposed membrane, not bulging membrane. This will be different. Exposed without pain, without contraction, so think in the exam. Infection, no cervical circulage. Bleeding, no rescue circulage. Uterine contraction, no cervical circulage. Consider rescue circulage or cervical circulage for a woman between 16 and less than 28, 27 plus 6 weeks of pregnancy with a dilated cervix, 2-3 centimeter, no problem. Exposed membrane, not bulging membrane in the vagina or prolapsed or the woman in contraction or in pain. Exposed membrane only and unruptured fetal membrane because PPROM is contraindication now for tocolysis or for circulation. So only exposed membrane without painful uterine contraction is indication for risk of cervical circulation and should be between this gestational age. When to offer tocolysis? Nifedipine is the best tocolysis. For a woman between 24 and 25 plus 6 weeks of pregnancy, you can consider to give nifedipine for a woman between 24 and 26, less than 26 by day, of pregnancy who have intact membrane, no tocolysis with ruptured membrane, and in a suspected preterm labor. So a woman in suspected preterm labor, there is cervical changes, you will offer nifedipine tocolysis. You will offer it between 26 and 34. So make yourself in clear and offer it between 24 and 34, less than 34, 33 plus 6. So consider to give between 24 and 26 and offer it between 26 and 34 or 36 plus 6. Actually, this is the challenging age between 24 and 26 and the criteria of the preterm labor, how much the child will live with disability or without disability. We are starting from 23 and the chances would be 30 without disability and 30 with disability. This is a famous recall question. 30 with disability and 15 without disability, and you will increase every week by 15. So 45, 30, this is a common exam question. That challenging age between 23 or 24 and 26 or even 27. So anyway, you will offer nifedipine between what? Between 24 and 34 plus 6. If a woman have suspected preterm labor or diagnosed preterm labor and should be intact membrane. Rupture of membrane is contraindication to offer tocolysis. Okay? Recommend, what will be the doses? Recommend the initial dose of 20 milligram followed by 10 to 20 milligram every or 3 to 4 times a day. Adjust the doses according to the uterine activity. The total dose should not or above 60 milligram will cause complication or will increase with a 3 to 4 fold associated or increased adverse effect, which will be the headache and hypotension. So I will give the woman the initial dose, which is 20 milligram and 10 to 20 milligram 4 times a day, not exceeding 60 milligram, or if you exceed 60 milligram, there will be headache and hypotension. So that's when to offer circulage, risk of circulage, and when to offer tocolysis. So if the gestational age between 24 and 36 plus 6, I will give the woman nifedipine, which is the first recommended tocolysis for a woman in a preterm labor. What about corticosteroid? When to offer maternal corticosteroid? Corticosteroid will give a benefit. What will benefit? It will decrease the risk of respiratory distress for 50% in all gestational age. Also, this is an exam question. So when to offer? For a woman between 23 and 24, discuss with the woman the benefit of corticosteroid. So from the challenging age, 23 and 24, I will discuss. From 24 again to 34, so you will offer corticosteroid. So tocolysis and corticosteroid are the same between the age of 24 until 34 or 36 plus 6. Tocolysis and corticosteroid. Why? Tocolysis is important to delay and give chances for the corticosteroid to act. Even it can delay the labor up to 7 days. So tocolysis, if no rupture membrane or no bleeding, I will advise the patient to have tocolysis. Corticosteroid, if the gestational age between 24 and 34 plus 6, I will offer corticosteroid. Less than this, I will consider or I will discuss with the woman the benefit of corticosteroid. Even after 34 to 36, I can consider to give the woman or better to offer. So think about corticosteroid for a woman between 34 and 36 weeks of gestation. So this will be the rules to play with it in the exam. The cholesterol between 24 and 34 plus 6. Corticosteroid, I will think about even if it's early, or I will discuss with the woman from 23, and I will offer between 24 and 34, and again I will consider between 34 and 36, 35 plus 6. The Arsogiro.
So drug of choice for tocolysis, is it ocibin or nifedipine?
Nifedipine is the first one.
Drug of choice.
The first choice is nifedipine, comparable effect and less socioeconomic burden. So nifedipine is the first choice, not atisopan. Not atisopan. Comparable effect between both nifedipine and atisopan. But the first line is nifedipine. Why? Comparable effect and less cost or less cost. Okay? So the first line is
Okay, sir.
nifedipine.
Thank you.
Welcome. The Arsogiro recommend that a single course may be considered. What is the course? Will be metamizazone intramuscular at a dose of 12 milligram 24 hours apart. So this will be the corticosteroid choice. Metamizazone intramuscular 12 milligram 24 hours apart, single dose. Magnesium sulfate, when to offer, when to consider. Offer intravenous magnesium sulfate between 24 and 30. This is the first difference here. To offer between 24, the challenging age, as we always offering, but I will keep it offered until less than 30. More than 30, I will consider. More than 30 to 34, I will consider to give intravenous magnesium sulfate. What will be the indication, or what will be the points to offer in the exam? The woman should be in established preterm labor. What is the definition of established preterm labor? It means she is 4 centimeters or more. So if in the exam he tells you 3 centimeters, no magnesium sulfate. It is not established preterm labor. And if you revise the criteria of established preterm labor in NICE guideline, it will be a regular contraction from 4 centimeters. So the NICE guideline define the established preterm labor from 4 centimeters. So I will not offer magnesium sulfate until the woman is 4 centimeters. Or you will do elective birth, induction of labor or cesarean section within 24 hours. The woman have a planned preterm birth, either cesarean section or induction of labor due to IUGR. So I will offer in this situation magnesium sulfate. I will offer again magnesium sulfate between 24 and 30 weeks of gestation, less than 30, 29 plus 6. If the woman have one of these criteria, established preterm labor, 4 centimeters or more, or a planned preterm birth, I will terminate this woman in the morning, or I will terminate her within hours due to complication. I will do a cesarean section. I will do induction of labor. So in this situation, I will start the intravenous magnesium sulfate. Otherwise, in the exam question, no criteria like this, so I will not offer magnesium sulfate. Consider intervention of magnesium sulfate if the woman between 30 and 34, less than 36. What will be the dose? The dose is the same as preeclampsia, 4 grams intravenous as a bolus dose over 15 minutes, then 1 gram per hour. Once you offer sulfate, you must terminate either a preterm labor or delivery within 24 hours, whichever is sooner. Does this clear? Are we fine till now in the preterm labor? Because I will give you a very difficult scenario now.
Sir, just please clarify about this rescue dose. It's written that if it is less than 26 weeks, we repeat the dose. So we give 2 injections 24 hours apart, or just 1 single dose of 12 mg? Please clarify this.
If the woman between 24 to 30, okay, you will offer intravenous magnesium sulfate if the woman have establish preterm labor, or I will terminate her within 24 hours. If the age between 30 and 34, I will consider to give magnesium sulfate. The dose will be 4 gram intravenous bolus. So the loading dose is 4 gram sulfate, magnesium sulfate, over 15 minutes, followed by intravenous infusion, 1 per hour, 1 gram per hour, until birth for 24 hours. Okay? Once sulfate, you should terminate.
I was asking about rescue dose of betamethasone, corticosteroids rescue dose.
It's only one dose, my dear. It's only one dose. Betamethasone intramuscular, 12 milligram, 24 hours apart. This is the recommended regimen by the heart surgeon. Even the woman on labor, you will start the corticosteroid. Okay? I think
Dr. Hany, for this 34 weeks, we can give the patient till 34 weeks this magnesium sulfate, or unless she is 4 cm, as you told her.
no, less than 34, 33 plus 6. Then you can give magnesium sulfate. 34 you will not give.
Yani it is not on contraindicated till now that patients till, for example, patient 33 weeks plus 3, for example, and she's 4 cm. I can give magnesium sulfate this mean.
For neuroprotection, you will give.
Yes.
Okay?
Yes. Okay.
So this will be the tricks. What will be? Any question till now?
Yeah, once we given a mec sulfate, means we have to terminate the pregnancy or no? Means sometimes suppose after 4 centimeter, we given a mec sulfate, we given also corticosteroid, we give also nifedipine, and suppose preterm labor means patient not ready to labor, then we can continue pregnancy or no?
I got the question. You will not start magnesium sulfate unless the woman will deliver, means establish preterm labor after 4 centimeters, then you will give magnesium sulfate. Or you will do cesarean section for the patient, or a planned preterm birth. Then you will offer for her the magnesium sulfate. Okay? You are not giving magnesium sulfate unless you will terminate the pregnancy.
It means in a nifedipine we can give in a suspected preterm labor, but mec sulfate we should give in confirmed preterm labor, is it?
Excellent. So nifedipine or tocolysis can be given in what? In suspected preterm labor, with exception if a woman have rupture of membrane or bleeding. So tocolysis is contraindicated here. You will offer dexamethasone only.
Okay.
So this is how to offer and when to offer. Corticosteroid, a suspected preterm labor. In this age, I will offer corticosteroid. Tocolysis, a suspected preterm labor. Magnesium sulfate, no. Established preterm labor. Or a planned birth.
Sir,
Everything is
if
fine?
patient yes. Sir, if patient is on magnesium sulfate and patient delivers before the magnesium sulfate dose has been finished, so if the baby delivers before the 24 hours, so we have to stop the magnesium sulfate as soon as the birth has been finished?
Which is sooner, yes. You are giving here for neuroprotection for the baby, okay?
Yes, sir.
This question make a lot of confusion on the main group, a lot of debate actually. But if you discussed it now with me, it will be very easy. Why? Because we know the rules. So a woman came in a preterm labor, 28 weeks. This have a meaning. 28 weeks, she can have all. She will have tocolysis, she will have corticosteroid, and I am thinking about magnesium sulfate if she's in labor. So 2 weeks, or she have 28 weeks with pregnancy and received a course of corticosteroid. So corticosteroid finished. 3 days back in a threatened preterm labor. Okay, so he gives you a clue here for tocolysis. What is the benefit of tocolysis? The benefit of tocolysis, it will give you a chance for the corticosteroid to act, and it will extend the pregnancy up to 7 days. So even the patient took corticosteroid, and I can give tocolysis not only for corticosteroid, but to expand the pregnancy if the woman have no PPROM or no bleed. Okay? No complaint. Now the patient complains of abdominal pain, mild irregular uterine contraction, presentation, side effect, or I don't know what is this, a paracervix 3 centimeter, next appropriate management. So the criteria of tocolysis and corticosteroid and magnesium sulfate. Magnesium sulfate is not met, so I will not offer magnesium sulfate. Corticosteroid, already she have corticosteroid. I will think about tocolysis if she's a preterm labor and no rupture of membrane and no bleeding. Okay, if any of these, I will not offer tocolysis as well. It will be expectant management. This is how to discuss a question or how to answer a question in the exam. Okay? This will be the evidence-based answer. The criteria of each one should be met. What to do and what not to do. Clear? Another question. Any question?
So, Dr. Hany, does it mean that this patient, she has already received steroid and she has been on tocolysis for steroids? Now she has come again with the preterm labor. We will give again tocolysis only?
If she took tocolysis, so she is already on tocolysis. The question are not full, so I am giving you the evidence-based answer for a scenario like this. I will not offer magnesium sulfate for a woman with 3 centimeters. Why? She is not an established preterm labor. Tocolysis, she already took tocolysis. Corticosteroid, already took corticosteroid. Either to be on tocolysis or I will wait and see. If she came 4 centimeters, we'll offer magnesium sulfate.
So what is the...
Excuse me, Dr. Hany, he is giving us an indicator of labor. He said that there is mild irregular contraction. In spite of, yes, it's 3 centimeters, but it's mentioned that there is mild irregular contraction. Will this indicate to give magnesium sulfate or not?
No, Dr. Khalid. Once she became 4 centimeters, which is the criteria of established preterm labor, then I will offer magnesium sulfate. This patient is not a candidate.
No, Dr. Hany,
Yeah.
I'm confused about the tocolysis. Do we give tocolysis twice? Or can we give tocolysis twice, or it is just for the sake of steroids only?
No, the benefit or the idea of tocolysis is to give the corticosteroid a chance to act. But if the woman in a preterm labor, tocolysis can extend the pregnancy for 7 days. That's why there will be a benefit of tocolysis. So continue the tocolysis regimen if the woman have no rupture of membrane or no bleeding. Why? You will improve the survival rate of the baby and the chances of the baby to survive. So she already started tocolysis and she received corticosteroid, but magnesium sulfate is not indicated. Does this make sense?
Yes, the answer here will be nifedipine. Is the answer right here administered nifedipine?
Forget about the option, forget about the question because it is not complete scenario. I am telling you the evidence-based answer.
So suppose this question comes, so what should be the answer? Is it nifedipine or observation just?
If there is nifedipine, I will continue nifedipine because she is already a candidate for nifedipine. Because it will delay the pregnancy. Okay. If she already on nifedipine, so expectant management or observation. Clear?
Dr. Hany?
Yes.
Okay, let's move.
If this patient, if in a scenario that it's about steroids, sorry, the question. So if I know that tocolysis is not given when there is if there's rupture of membrane, but if she's not had, came in contracting and rupture of membrane, but not had the steroid, do we give it for a short time to give time for the steroid or not?
We are giving the main idea, as I told May, the main idea of tocolysis is to give the corticosteroid a chance to act, to improve the lung of the baby. The preterm labor will give you a respiratory distress baby, and the corticosteroid decrease the rate of respiratory distress. So you are giving corticosteroid and tocolysis to this benefit. But because of tocolysis can give you another benefit, which will be expanding the pregnancy and stopping the contraction. So you will give the baby a higher chances to live. Every 1 week will make difference. Every 1 day will make difference.
My question, if there is a SROM, if the membranes are ruptured, but she'd not had steroid, can I give her tocolysis to give chance?
No,
if she's contracting.
Membrane ruptured is contraindication to give tocolysis May. And this is an exam trick. You will not offer tocolysis with ruptured membrane for the risk of chorioamnionitis. This is a new GTG.
Okay, thank you.
So rupture of membrane, no tocolysis. Bleeding, no tocolysis. The idea of tocolysis to give the corticosteroid a chance and to expand the pregnancy up to 1 week more to increase the expectation of the baby. So this question is not for magnesium sulfate, either to continue the tocolysis regimen or to what? To wait and see, observation. Clear?
So it's not mentioned anywhere that tocolysis is started. So we assume that tocolysis is started in the scenario because she has received steroids, because nowhere in the question it says she was on tocolysis.
Yes, it should be on tocolysis. Because tocolysis is already
so we assume
already indicated in this scenario. Okay?
Yeah, so we assume that she's on tocolysis. It's only given that steroids were given 3 days ago. Nothing about tocolysis is really mentioned in the question.
Yeah, because already the patient took corticosteroid. She already take tocolysis. Okay? If she are not in tocolysis, so we can continue the tocolysis regimen because still the patient is a candidate for tocolysis, not for magnesium sulfate. Okay? There is no magnesium sulfate now. Should be after 4 centimeters. Let's move to another scenario. A previous cesarean section with a preterm labor at 28 weeks. So she is a candidate for all. Received steroid again, shows steroid finished. It's only 1 day. And now having a bleeding. So no tocolysis, stop tocolysis. BV at home, bleeding per vaginal at home, now settle. Now complain of pain. Retapolutrus, 3 centimeter dilated. And ultrasound shows a breach and FI19. What will be the next line of treatment? Is this woman a candidate? I will not offer tocolysis because of bleeding. So is this woman a candidate for magnesium sulfate?
No.
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 Because maybe she will go for
it's
cesarean.
She's
Bleeding, breach.
Unless she have 4 centimeter, or I will do CS for her. A tender scar. The bleeding came back again. I want to save her life. So if she's 4 centimeter, or I will go for cesarean section, I will give her magnesium sulfate, no tocolysis. This is the evidence-based answer. Forget about the scenario, forget about the option. This is all wrong. I am giving you what you will do in the exam. Does this make sense?
Yes, sir.
Of course.
Can you please repeat it? Can you please repeat it?
I will
This
go
question?
step by step. Like I told you, by evidence-based answer. I will read and my background, the tricks. A previous cesarean section in a preterm labor. She already took a steroid and she have a bleeding, so no tocolysis. I will stop the tocolysis regimen. So what I will think now, I will think about magnesium sulfate. Why? Because offered before 30 weeks of gestation. This woman is 28. So I will offer magnesium sulfate only if the woman 4 centimeter or she have a bleeding, and I will do cesarean section for her. Elective preterm birth, I will offer magnesium sulfate in this situation. This is the evidence-based answer for this question. Forget about all this. Think when and what to give and why you will pass the exam. Nothing mentioned in the question without a meaning. He is pushing you to choose one single answer. According to what? According to the basic, what I told you. Does this make sense?
Sir, so your answer should be F.
Forget about the question and forget about the answer. This is the way to think in the exam. The question is missing and the option is missing. I am telling you the evidence-based how to answer in the exam. Okay?
Sir, so here we will give the patient Mexel and then we will perform a cesarean section. This should be the answer, no?
If you will do, if he told you in the exam the bleeding is heavy, so magnesium sulfate and category 1 cesarean section. Clear?
But here bleeding is settled.
So you will not do.
But now no complaint, Dr. Hany. No complaint now. No pleading. You told that it is settled already.
That's I am telling
we
you.
can
Yeah,
give
so
her
just
I will not
observation.
offer magnesium sulfate until or unless the woman is 4 centimeter, or I will go for cesarean section.
Yes.
But here
now
the
I can
patient
give
is having
magnesium
irritable
and
uterus.
time management.
It's not allowed to speak all in the same time. Just one, please. So this will be
Dr. Hany,
okay.
this patient is having an irritable uterus, right?
I am not answering this question. I am telling you what to do in the exam. The scenario is missing, my dear. Okay? If you are thinking about the patient in emergency, like she have irritable uterus or a tender uterus or a tender scar or a brush placenta or the bleeding is coming, if he told you like this, you will go for magnesium sulfate and cesarean section. Does this make sense? Okay? This is the evidence-based answer for this scenario. The last one, a multigravida with a 22 weeks of gestation. Is there anything at 22? Only glycolysis. Think or discuss. Even 23, not 22. Admitted with pain on examination, uterine contraction, cervix is 2 centimeter, magnesium sulfate between 24, membrane found prolapsed in the vagina, so expectant management. I will think about only tuberculosis because tuberculosis is card here. You see here, discuss.
But discuss is from 23 to 23 plus 6 weeks.
23.
And the patient is here is 22.
So it is not.
Rescue circlage.
Even it is
Rescue
not.
circlage can be done.
It is not for corticosteroid.
Yes, we can go for rescue circlage in this patient.
It is not a candidate for anything. That's why I am telling you he is giving the gestational age for a clue. Why he mentioned 22 in this question? To be away from the challenging gestational age. So, expectant marriage. This is how to answer in the exam. Okay? The preterm labor is killed now. An easy marks to collect in the exam. Let's move. You will remember me in the exam, and I hope you will pray. Okay?
So, Dr. Hany, I found out, if at all, if in the question, if it's mentioned that corticosteroids have been given, then we need to assume that patient has already on tocolysis. Am I right?
It should be a stepwise manner like this. Tocolysis, corticosteroid, magnesium sulfate. This is
all right.
You should think about why you are giving tocolysis to give a chance for the magnesium sulfate. Okay? For the risk of circulage, no bleeding, no pain, no infection, I will offer risk of circulage between 16 and 28. Otherwise, no. Okay?
Yes, yes, doctor.
This is all the tricks of the preterm labor. Let's move to another exam trick. Shoulder dystocia is a very easy guideline and a very important life-threatening condition and a drill and a very important daily practice. You should know each single step about shoulder dystocia. I know already you are well prepared, but I will add a little bit salt for all of you. How to think and how to answer about shoulder dystocia. It's also a stepwise manner. If you face shoulder dystocia, the first step is to call for help. The first step is to call for help. Once you diagnose the turtle sign or you find shoulder dystocia and the head is retracted again for the woman buttock, push the help buzzer to call for help. Okay? Stop, send to, stop pushing, bring the woman to the edge of the bed. So call for help, stop oxytocin, stop pushing, and bring the woman to the edge of the bed. The first maneuver to do macroper with suprapubic pressure. And the suprapubic pressure have a very important safety point. From where? From the side of fetal back. Why? To decrease the bisacromial diameter. So the assistant, if the baby is facing here, the assistant should stand and do the suprapubic pressure from here. The baby is looking here, so the pressure should be from this side. Why? If you pressed the baby shoulder from here, you will decrease the bisacromial diameter. If you came here on the other side, you will expand the shoulder and increase the impaction, which is a bony impaction between the baby shoulder and the symphysis pubis or the sacral promontory. So macroparts, which you will put the size of the woman on her abdomen, her ears or her knee to reach the ears, extreme flexion with abduction. Why? To strengthen the lumbosacral angle. With suprapubic pressure from the side of fetal back, give you success rate about 90%. A very famous figure for the exam. If this failed, so you will do what? You will go for the second step. Internal maneuver. The RCOG recommend to do internal maneuver first. Why? Because posterior arm delivery can cause fracture. Fracture humerus is 2 to 12%. So to avoid fracture, you will go for internal maneuver first to rotate the shoulder from the anteroposterior diameter to the wide oblique diameter. Either here, your dominant hand will be on the back of the anterior shoulder, and the other hand will be on the front of the posterior shoulder, and you will rotate the baby to the oblique diameter. If this failed, you will try to rotate in the other side. Internal maneuver first, not delivery of the posterior arm. Episiotomy to make your life easy. It will not improve the impaction. It's a bony obstruction. It is not soft tissue obstruction. Episiotomy only for you to do the internal maneuver and try to deliver the posterior arm. This is how to think in the exam. If this failed, you will call your senior, inform your consultant. Why? Because you now need to repeat or to put the woman in the all four and repeat all. The all four, the woman will face down and the success rate will be 83%. If this failed, you will go for destructive technique, which is cleidotomy, fracture of the clavicle, or symphysiotomy, opening the symphysis pubis, or the Finelli maneuver, which you will put the head back and do cesarean section. Does this make sense? All these are a safety point. I will not speak about the details of the guideline. I am giving you the tricks for the exam. Powerful help, McLopert with suprapubic, 90% success rate. Episiotomy for your life only, to make your life easy, to can do the internal rotation. Episiotomy, consider if it will make the internal maneuver easier. So you will start by the internal rotation first. then delivery of the posterior arm. How to do this? This is the macroper to flex and abduct the legs. The knee should be near to the ears. Complete flexion and abduction. Why? To straighten the lumbosacral angle and widen the anteroposterior diameter to improve the impaction. The suprapubic pressure should be from the side of fetal back. Why? Either to be rocking or continuous to decrease the diameter of the shoulder. So you should, or the assistants will stand. The nurse or the assistants will do the suprapubic from this side. The baby is looking here. The suprapubic should be here to decrease the biacromial or the disacromial diameter. You see here, this is macroper. This is the suprapubic pressure where you will find the fetal back. The fetal back is here. So the assistant will be here. Internal maneuver first to avoid fracture of the humerus, 2 to 12%. How to do? You will put your hand in the cubital fossa, bring one arm, sweep it on the front of the chest of the baby to deliver the posterior arm. If the internal maneuver fails. Let's see another scenario or a mini mock or a question. I will do like this all the session today. Each topic with the exam question to know what is the evidence-based answer. So a lot of option in the MEQ, you are not reading the option. You will find 100 options. Don't read it. Go for the heading. You will find a lot of options, even it will make you confused before you starting the heading. What you want, what's the instruction, what the RCG wants from you. So leave the option in the MEQ and go for the heading. He wants you to what? For each clinical scenario described, to choose the single most appropriate management option from the list above. So he will speak about the management. Then I will go to read the question. I'm always advising about this. A scenario, a woman with 30 years old who is bara 2 attends the antenatal clinic at 37 weeks of gestation to discuss about the mode of delivery. She had her last delivery 2 years back and gives a history of difficult forceps and the baby have complication. What will be the answer? The baby already developed herpes palsy. So a counseling in the clinic. So you will think about what? Who knows?
Elective cesarean section after 39.
Recurrence is high, so we can offer her CM.
Excellent. Okay, another scenario. A 30 years old woman, bara 1, delivered vaginal, presents to the labor at 42 weeks of gestation with regular uterine contraction. Clinically, the baby was big, 4 kg. Her previous child was also big, 4 kg. She progressed quickly until 7 cervical dilatation, but subsequently she took 8 hours to progress for full dilatation. So delayed progress. I will not speak about the intrapartum care or the partogram rule now. I know a lot of my candidate and a lot of my colleagues, speak about the intrapartum care. And vaginal examination reveals an occipital posterior procession and the fetus presenting +1 station. The station, or you find the head already delivered and a turtle sign is noted following delivery of the head. So what you will do?
Call for help.
Call for help. Call for help. Call for help.
This is
Suprapubic. Followed by macrobuds procedure.
There is nothing to do. There is no other option to be right in this scenario unless to call for help. This is the evidence-based answer. Another scenario. A 40 years old or a 42 years old woman, a primary gravida, present to the labor ward with a spontaneous labor at 38 weeks of gestation. She had diabetes and on insulin. Her last scan at 36 weeks of gestation reveals an established fetal weight 3.7. During labor, she needs augmentation, oxytocin augmentation, to progress to full dilatation. 2 hours after pushing, she had a spontaneous vaginal delivery with the head on the perineum. An emergency bazaar is born. So the midwife called for help. This is the way in UK to call for help. To push the red bazaar or to push the emergency button or the emergency bazaar by the midwife. On entering the room, you notice the patient in the macropart position and the midwife giving traction to the fetal head. What will be the evidence-based answer here?
Pressure.
Already. I will not stop.
Physiotony and internal rotation.
Physiotherapy.
The patient is already in macroparts. I will do the suprapubic pressure to increase the success rate of the macroparts up to 90%. So I will do the suprapubic pressure, or the assistant will do the suprapubic pressure from where? From where?
From the side of fetal back.
The fetal back.
From the side
Fetal
of
back.
back to decrease the pisacromial diameter.
Yes.
So the evidence-based answer here will be the suprapubic pressure.
Teresa, what about stopping the center because she's on center?
My dear, the cento is stopped once you noticed. Call for help. Stop cento before macroparts. Stop cento, discourage pushing, and bring the woman to the edge of the bed. Remember the chart. I told you it's a flow chart, a stepwise answer in the exam. Okay?
So if they didn't mention it, I assume they've done it since they reached the second step.
If he reached with you that the woman already in macropart, so you called for help and you stopped your cento and you bring the woman to the edge of the bed and you did macropart, so suprapubic pressure. Okay? Clear? Let's see this scenario. A 30-year-old woman with BMI 41, para-1, present with labor ward about 40 weeks of gestation and spontaneous onset of labor. Clinically, it is difficult to assess the size. The woman have high BMI. She has a high BMI. A gross scan at 36 weeks of gestation revealed that the baby weight is 3.8. Then 2 hours later, she have vaginal delivery, but the midwife put out the obstetric crash call. So she called for help. After noticing a turtle sign, the registrar at 10 tries to do the rotational maneuver following the macropart. So he did macropart, suprapubic pressure, and went to the rotational maneuver. And he put the macropart position, fails to deliver the impacted shoulder. So what you will do after the internal maneuver?
Posterior.
All force.
No. The evidence-based answer was delivery. Yes. Excellent. So it will be the posterior arm. Let's see the last scenario. A 30-year-old Asian, it's a risk factor, presents with the labor ward at 40 weeks of gestation with a spontaneous onset of labor. She is unbooked. She have never been booked before. No appointment, no scan, no blood test. And clinically, the baby appears big. The blood sugar level is high. She progressed slowly for dilatation. The cervix, after 18 hours, the registrar called in anticipation of shoulder dystocia. She is delivered, or the head is delivered. Then an obvious turtle sign, diagnosed shoulder dystocia. The obstetric crash calls or the emergency bazaar was put out. All maneuver was tried and removal of the posterior arm failed. So What will be
All
the
four
answer?
position.
Gaskell's manual.
All four position. All four.
All four. Excellent. The success rate of all four?
83%.
83%.
This is the evidence-based answer to answer in the exam. Okay? Let's move to another exam tricks. I will be fast. I know a lot of my colleague and a lot of mentors discuss all this. Even Prenail Tier was involved in today's session, but I will think different, little bit different. A Prenail Tier.
Sir, I have a question, sir, before you move ahead.
What will be?
Hello.
Sorry, any question?
Yes, sir. Yes, sir. Sir, that first question where there was an Erb's palsy in the previous pregnancy, why to offer cesarean section?
The baby have complications. The woman already have a complicated delivery, a difficult forceps, and the baby have herpes. So consider cesarean section. When to consider cesarean section? In perineal tear or in shoulder dystocia? Can anybody answer? When to think about or consider cesarean section here in the perineal tear or in shoulder dystocia?
Shoulder dystocia.
And when to
in shoulder dystocia if she has any affected baby, and in perineal tear if she is symptomatic.
Of perineal tear, if she is symptomatic and there is an anal defect by the endoanal ultrasound or the manometry more than 30 degrees. If you search it well in the end of the guideline of perineal tear, you will find what I am telling you now. To consider cesarean section, if the woman is symptomatic, still she is suffering from incompetence and the perineal defect or abnormal endoanal ultrasound or abnormal manometry, if you find the defect in the anal canal or the anal sphincter more than 30 degrees, find this in the guideline. This is your homework today. When to do CS or when to consider cesarean section for shoulder dystocia and for perineal tear. You will find it in the details of the guideline at the end of perineal tear. So let's think different about perineal tear. 1, 2, 3, 4, you know already. 1 or degree or first degree perineal tear, it will be the skin and the vaginal mucosa. 2, you will find the superficial perineal muscle. 3, it will be A, B, and C. 3, A, B, and C. Less than 50% of the external anal sphincter, more than 50% of the external anal sphincter, both external anal and internal anal tone, C. So A, B, and C, I will not touch this. I just gave you the exam tricks. Complete perineal tear or fourth degree perineal tear if the anal mucosa is completely torn. So first degree, second degree, 3, A, B, C, and fourth degree. How to suture, how to do, how to examine. BR is a safety point. Why? Rectal examination is a very important safety point. Why? To know and assess the type of tear and to do the ruling test. You will put your index in the anal canal and you thumb on the perineum and rule in between to find the defect if you have a complete tear or no. So this will be the repair. The anal mucosa can be sutured by continuous or interrupted suture, which will be 0.330 vicryl. It should be braided, no BDS, long time, long tensile, irritant, causing fistula. So this is the exam trick. No BDS in the anal mucosa, 30 braided vicryl. Okay? After that, how to suture, interrupted or continuous, the anal mucosa. Let's move to the internal, the white sheet, which is the internal anal sphincter. This is not to do with overlapped. Why? How you will overlap here? The tear is here. It should be end to end, either interrupted or matrix. You cannot overlap or you will disturb the anatomy. So in the internal anal sphincter, never to do overlap. It's against the anatomy without any intent to overlap. So the type of suture, the suture material is an exam question. Again, or I will proceed. I am going. Am I clear till now? I will proceed.
Yeah. Yes, sir. Yes, sir.
Okay. So no overlap in the internal anal sphincter, either interrupted or matrix suture without any intent to overlap. In the mucosa, no BDS. Here in the internal anal sphincter, bicryl 2-0 braided or BDS 3-0, both are valid. Okay, let's move another step. So, the torn inner mucosa should be repaired with a suture using either continuous or interrupted technique by 3-0 bicryl, no BDS, long tensile, long time causing fistula in the mucosa. No BDS, again and again and again. No BDS in the anorectal mucosa. For the internal anal sphincter, interrupted or matrix suture with braided bicryl 2-0 or BDS 3-0 without any attempts to overlap. Why? Against the anatomy. How you will overlap an intact above a torn down internal anal sphincter? So this is the second trick. The third trick, when to do overlap. The external anal sphincter will be like this. If you have a full thickness cut, so you can overlap. A partial thickness, you cannot overlap. You will do end to end. I will highlight this in the next chart. So, for repair of a full thickness internal anal sphincter tear, either to do overlap or end to end, because you can do overlap only here. Anatomical repair, only here. A full thickness cut, you can do overlap. Otherwise, there is no overlap. Method can be used with equivocal outcome. So either to do end-to-end or overlap, both are fine. The same suture for the internal sphincter, bicryl 2-0 or BDS 3-0. Partial thickness, so end-to-end, no overlap. So if he told you less than 50, 3A and some 3P tiers, so less than 50% or 50%, you cannot do overlap because the remaining muscle is still intact. How you overlap an intact muscle? So only end-to-end technique, no overlap here again. Only you will do overlap in complete cut in the striated external anal sphincter tear. Another trick to bury the surgical node because the risk of migration. Burying the surgical node pins the superficial perineal muscle is recommended to minimize the risk of not migration or suture migration. It will be about 7%. How to do? This is the external anal sphincter, complete cut. So you can do end to end. I will take the needle from here, 0.5 centimeter, half centimeter here and half centimeter here. And again, half centimeter here and half centimeter here, and I will stitch. So this is called end to end. It will appear like this. Overlap, I will take from here 1.5 centimeter and here half centimeter from the other side. So this end will overlap the other end. So how I will overlap in partial thickness? In partial cut, how I overlap? It should be end to end in 3A and 3B. So 50% of if the muscle is cut, I can do end to end. I will not do overlap unless a complete cut. Is this clear now? I think I killed the perineal tears.
Yes, sir.
Okay. What is OASIS? And what is the OASIS care bundle? It's a project between what? Between the NHS and the RCOG. The RCOG did a project to improve the woman health and improve the woman care. What to do? OASIS care bundle, actually, it's a 4-step. To discuss the woman about perineal tear, to do episiotomy once indicated, And if you need, it should be 60 degree at crowning to avoid torn or extending the episiotomy and making a tear. And a documented manual perineal protection, not hot compress, manual perineal protection, hands-on technique is higher and involved in the project of OASIS between the NHS and the RCOG. So you will do a manual perineal protection. After that, you will examine the perineum. As I told you, the rectum examination is a very safety point. Why? To assess the tear and know the extent and to see the defect by ruling the muscle in your hand, the ruling test. Does this make sense? Am I clear till now? Let's do a mini mock, a practice, a question, how to answer and how to choose. A lot of options, as we discussed. I will not read. I will go directly for the heading. What you need, what the RCOG need from me. For this case or the case described below, choose the most likely suture material and technique. So I gave you the evidence-based answer now. No overlap, except in what? Complete external anal sphincter tear. Let's see the first scenario. A 35-year-old woman delivered by a nipple-bound forceps on vaginal or rectal examination. She was found to have a tear involving the internal and the external anal sphincter. The rectal mucosa, it's intact. So, what will be the degree of this tear?
3C.
3C.
How to suture?
20 vicryl or
20 vicryl or 30 PDS.
20
interrupted.
Yes.
20 vicryl or 30 PDS?
30 PDS or 20 vicryl?
Excellent, excellent. 20 vicryl or 30 PDS. Is there any overlap here?
No overlap.
External anal sphincter can be overlapped. External anal sphincter can be overlapped.
Yes, that's true. But in the internal anal sphincter, I'm asking, is there any overlap here?
No, sir, no.
I will do end to end. After that, I can do overlap or end to end to the external anal sphincter because complete tear. So the answer will be 30 PDS with end to end technique because both can be sutured by end to end. I will not go for sophisticated or yes, I can do the external anal sphincter. End to end in the scenario, so this is the best answer because both are comparable effect. Okay? Does this make sense? Another scenario. A 25-year-old woman, multi-para, has a normal delivery. When the midwife started suturing, she could see the tear extending to the anal mucosa, so 4th degree perineal tear. On further examination, the doctor confirmed this. So, what will be the answer?
Vicryl.
Grade 4
Vicryl.
30 vicryl.
30 vicryl. Interrupting sutures.
Yes, excellent.
Interrupting sutures.
Excellent. Either to be interrupted or continuous. So the answer will be 30 vicryl or polyglyctin sutures. Another scenario. A 25-year-old woman, multiparous or primiparous woman, have been spontaneous vaginal delivery with a tear involving the vagina. On further examination, the external anal sphincter was partially torn.
Into it, 3B.
30 PDS with overlapping techniques.
30 PDS with end-to-end technique.
End-to-end.
No overlapping.
Because
30 PDS or 20 vicryl with no overlapping.
Excellent. I can see that all of you got my tricks. So now the answer is clear. There is no chances to do mistakes. Easy marks to collect in the exam. So the answer will be 3 BDS with end-to-end. No overlap in a partially taught. How I will do overlap? Half of the muscle is still intact. Okay, now I will move to a very important topic for the exam. Small for gestational age. How to think, how to answer, how to choose in the exam. I have a screening chart. How to screen for small for gestational age. I know all of you know about this, but I will just highlight the exam point. At booking in the first trimester, at the anomaly scan at 20 weeks, and what I will do in the third trimester. If I collect 3 from this minor, I will have a gift. What will be the gift? Uterine artery Doppler at 20 to 24, a 3 minor risk factor as the age 35 or more, IVF, pregnancy, nulliparity, BMI less than 20 or between 25 or 35, smoker less than 10 cigarettes. From 1 to 10, less than 11. If 11 or more, so it's a high risk factor. If you collect 3 of these minor risk factors, you will have a gift in the exam. What will be the gift? Uterine artery Doppler between 20 and 24 weeks of gestation. If this became abnormal, I will go for serial assessment of the umbilical artery Doppler and the fetal size from 26 to 20. If normal, then I will do assessment of the fetal size and umbilical artery Doppler in what? In the third trimester. If normal, I will repeat the assessment in the third trimester. If abnormal, I will go for serial assessment from 26 weeks of gestation. If I got one only risk factor, I will go directly for serial assessment. What are the major risk factors? The age, the cigarette, the paternal, the father or the mother is small for gestational age, a previous stillbirth, previous small for gestational age, daily vigorous exercise, diabetes with vascular, chronic hypertension, renal impairment, antiphospholipid syndrome, heavy bleeding, and small or little pregnancy-associated plasma protein B, plasma protein A, less than 4 at the first trimester is a high risk factor for small for gestation. Always coming in the exam. This point always coming in the exam. He will tell you at the booking, the pregnancy-associated plasma protein A is 0.3. So a major risk factor for small for gestational age, you will go for a serial assessment from 26 weeks of gestation. If the woman is obese, the BMI more than 35, or a large fibroid, it will be difficult to assess the centrifundal height. That's why it's considered as a high risk factor, and you will go for a serial assessment. At 20 weeks, you will see if there is any fetal abnormalities, any fetal echogenic bowel, a hint from fetal anomalies, then you will go for assessment or a serial assessment from 26 weeks again. In the third trimester, you will reassess if the woman have, you will reassess in the third trimester if the woman have only uterine artery Doppler, you will reassess again in the third trimester. Why? Because she have a 3 minor risk factor. Or if the woman have any of these, I will reassess again by doing what? Serial assessment of the fetal size and umbilical artery Doppler. If the woman have also bleeding or preeclampsia or antepartum hemorrhage or abruption, I will go again in the same. So this will be the rules of screening and always coming in the exam. Correct 3 and you will get 1. Collect 1 and you will get the serial assessment from 26. Okay? Is this point clear? Because I will move to another thing.
Dr. Hany, one second. This reassess at 20 weeks is only for high risk factors, or this is for both high risk and low risk?
Usually you are doing reassessment at 20 weeks. If the woman collects 3 factors, reassess her again at 20 weeks because you are doing anomaly scan. If you find a low PAPA at the booking or fetal echogenic bowel at the anomaly scan, this is a hint that the baby have anomaly. It can be a Down or it can be any other anomaly. Fetal echogenic bowel at anomaly scan can be considered as a risk factor. So you will go for serial assessment from 26 at 28. And if the woman have preeclampsia, you will give her aspirin at 12, not less than 16. You will give it from 12, means less than 16. Okay?
Doctor,
Yes?
what will make if in the third trimester we find severe pregnancy-induced hypertension or preeclampsia?
Reassessment.
In the last column.
Reassessment. Serial assessment of the fetal size and umbilical artery Doppler.
If in the third trimester we find that there is hypertension or preeclampsia, we can go for umbilical artery Doppler like this.
No, just give a time. I will tell you something in the next slide. This is the screening.
Okay.
Dr. Hany, can I ask you a question?
Sure.
Yeah. When you said that major risk factors, one risk factor is there, they would go for a serial assessment of fetal size and umbilical artery Doppler from 26 to 28. And what if at 20 weeks assessment, they get one of the major factors again, like PAPA being less than 0.4 or fetal?
At that booking. Because already you are booking all the woman for anomaly scan at 18 to 21 weeks. So you will reassess the woman again. So the first step at booking, the second step at the anomaly scan, because you already have risk factors.
No, my doubt was
will be the action. Either to
Doctor, my doubt was if she has one major risk factor at booking and she does not have any risk factor at anomaly scan, can she directly again go for serial assessment at 26 to 28?
That's true, because if you get one, as I told you, if you get one from here, you will go for a serial assessment. It is indicated.
Okay.
If
Thank you very much.
If the woman age only more than 40, so you will do serial assessment for the fetal size and the umbilical artery Doppler from 26 weeks. Okay? One risk factor only.
Even if she does not have one
is enough to do this.
Yeah. Okay. Thank you. Thank you very much, Doctor.
Let's move to the exam question. This is, I am not giving you the details of the guideline. I'm giving you only the tricks for the exam. You should know all this. What is the umbilical artery Doppler? This is an ultrasound or a Doppler ultrasound to know what is, I will classify the woman according to what? This is called the systolic pulse, or this is called the systolic higher pressure, and this is the end of the diastole. In the baby umbilical artery, there should be a flow at the end of the diastole. Why? To give the baby the nutrient and oxygen. So the end diastolic pressure is there. So normal. There. Normal. Reduced. Absent. Reversed. This is what you mean by a normal umbilical artery Doppler. Normal umbilical artery Doppler. Reduced in diastolic velocity, absent in diastolic velocity, and reversed in diastolic velocity. So this is the criteria to classify or manage the small for gestational age. Does this make sense? This is the criteria of the Doppler. If you find the end diastolic volume is there, the baby have blood in the diastole. So normal umbilical artery Doppler. So I will repeat every 2 weeks. If normal, why? Because the woman already has a risk. If normal, already I will repeat after 2 weeks. Fortunately, if abnormal, absent or reversed, reduced, absent, reversed. Clear? I will go for the tricks of the exam. How to manage a small for gestational age. You should have a history or a low sympathy fundal heights. So in the exam question, he will tell you the woman have a history of previous small for gestational age. The woman have a history of reduced or a history of low birth weight. The last baby was about 1.5 kg. So a high risk small for gestational age fetus or neonate based on history, biochemistry, low papa, or uterine artery Doppler, which is the screening, a moderate prediction to small for gestational age at 20 to 24. So a high risk history or a sympathy fundal height less than the 10th centile. If you find this, you will go for the fetal biometry, which is abdominal circumference or estimated fetal body weight less than the 10th centile. If you did this and the baby is more than 10th centile, it is not small for gestational age. And this is an exam trick. So the woman have a history even with small sympathy fundal height small, and you did umbilical artery, you did abdominal circumference, and the estimated fetal body weight more than the 10th centile. So it will be like this. This is the centile here. This is the 10th centile, and this is the 50, and this is the 100. So the woman does not fall here. She's above the 10th centile, 15 or 50 or anything like this. So it is not small for gestational age. I will not be here. I will be in the gross scan. I will be routine assessment. I will be follow the patient, not in the small for gestational age. To follow this chart, the baby should be abdominal circumference or estimated fetal body weight done and less than the 10th centile. Does this make sense? A history and a sympathy fundal height, any of these, and I did a fetal biometry, which is the abdominal circumference or the estimated fetal body weight less than the 10th centile, then I will go for the umbilical artery Doppler. Okay? I think...
Dr. Hany, one question here.
Oh.
Suppose a patient is having a previous history of small for gestational age and now the scan is normal. But we have to apply her that chart, previous chart, no, that serial scanning from 26 weeks, right?
This is to manage. This is the screening. To diagnose, you will use the screening for the history or the sympathy fundal height. If you find any of these, you will go to diagnose. What will be the diagnose? The abdominal circumference or the estimated fetal body weight. Other than this, if the baby is more than the 10th centile, means on the 50th centile, or the gross is fine, so the baby is not small for gestational age, and you will forget to do this in the exam. That's why I stopped here. To follow this chart, the baby should be IUGR, small for gestational age, less than the 10th centile. Does this make sense? Okay? Clear?
Yes, okay. Clear.
Okay. So the first exam trick, and most of us falling on this trick, a screening, I need to compare by fetal biometry, which is the abdominal circumference or the estimated body weight. Less than the 10th centile, I will go for the umbilical artery Doppler. Normal, repeat fortnightly. Fortnightly means every 2 weeks. I will not speak in the details. I will give you the tricks only, because you know this already. So, repeat the ultrasound, which is the abdominal circumference and the estimated fetal body weight. Every 2 weeks fortnightly, the abdominal circumference, the umbilical artery Doppler, and the middle cerebral artery Doppler after 32 weeks. This is a very important point. You are not doing the middle cerebral artery Doppler in preterm. You are doing it in term, baby, after 32 weeks. Why? Because he has a good diagnostic point to detect the fetal anemia. Okay? So, after 32 weeks to time the delivery and detect fetal anemia, the answer will be middle cerebral artery Doppler. So I will follow the baby with umbilical artery Doppler, abdominal circumference every 2 weeks. From 32 weeks, I will time the delivery by middle cerebral artery Doppler. I will do induction of labor. Otherwise, if there is static growth or the baby became IUGR, I will go for cesarean section. If I did cesarean section or I am planning to do cesarean section, I will give corticosteroid. If you find the umbilical artery Doppler is reduced but still there, as I told you in the previous slide, still the end diastolic velocity is there, not absent or reversed. The baby is still having a blood in the diastole. So I will do what? The answer will be repeat of ultrasound, weekly abdominal circumference, and twice weekly umbilical artery Doppler. Till what? Till I do induction of labor or cesarean section. Okay? I will do cesarean section if there is a static growth or if there is any abnormal middle cerebral artery Doppler after 32 weeks of gestation. So recommend delivery by 37 weeks. Consider steroid if you deliver the baby by cesarean section. If severe IUGR, so the baby cannot tolerate induction of labor, I will go for cesarean section, or a static growth. The baby is not going for 3 weeks. Why 3 weeks? To make difference in the abdominal circumference and the estimated fetal body weight. If you find that the baby is not gaining weight and 3 weeks difference, so deliver the baby. So I am doing here the umbilical artery Doppler, and the end diastolic velocity is still there. If it became absent or reversed, so I will refer the baby for fetal medicine specialist. Why? Because absent or reversed umbilical artery Doppler should be followed by weekly abdominal circumference and weight and daily umbilical artery Doppler and ductus venosus Doppler. A very important exam question. In preterm labor or preterm birth, I am timing the delivery by ductus venosus Doppler. When to time the delivery? Between 30 and 32 weeks. You can consider to deliver the baby at 30 to 32 weeks. Even the ductus venosus Doppler is normal. Because what? Because already absent or reversed in diastolic velocity. It is not the time to discuss all the details. I am giving you the tricks where you hit to get marks. This is the marks. Am I clear?
Excuse me, sir.
Yes, sir.
Sir, one question, please.
Yes.
Sir, if fetal biometry is above 10 centile, like this, so we will continue the serial assessment.
If
we will not do this IOT.
Is above the 10th centile, it will not be here. It will be the serial gross scan.
Okay, sir. Yes, sir. Thank you, sir.
This is a trick. This is a trick in the mock exam. You destroyed one question, Mariam, now.
Yes, sir.
Thank you, my friend. So, does this chart clear with all the exam tricks? This is a trick, and this is a trick, and this is a trick. And after that, a lot of tricks. And here, a middle cerebral artery in the term, ductus venosus Doppler in the term. Even normal, I will do cesarean section between 32 and 32 weeks of gestation. Why I didn't speak about induction of labor here? I will never induce an absent or reversed umbilical artery. It's a cesarean section at 30 to 30 weeks. The follow-up by ductus venosus Doppler. Daily. Clear? Let's move. If you don't have ductus venosus Doppler, this is also another trick here. You will follow the CTG. Which parameter in the CTG? It's the short-term variability. It should be less than 3 to terminate or to deliver the baby. This is also another RSOG trick. If you don't have ductus venosus Doppler in your unit, what you will do? I don't have fetal medicine. And this is another trick actually in the mock exam today. So I am solving the question before the mock exam. Okay? Let's do the mock exam. This is a woman, or this is a question here.
Sir, one doubt.
Okay.
Can we induce the patient when she has come with Doppler changes, even for the mild or normal also?
When you are doing the assessment or the screening,
After assessment, sir, if it comes to be IAC is less than 10 centile, but a normal Doppler, we have to deliver around 37 week. So can we induce her because keeping that Doppler changes are normal, or should we have to take her for C-section?
the guideline, my dear, no. If it is normal, you will start the induction of labor at 37 weeks. This is what I told you. You are going with the first arm here. This one. You are here. Delivery by 37 weeks of gestation. Involvement of senior. Induction of labor or cesarean section. If everything is normal, I will do induction of labor at 37 weeks. If there is, you see here, recommend delivery by 37 weeks if the middle cerebral artery Doppler less than the 10th centile. Consider delivery if there is a static growth after 35 weeks for 3 weeks. And do cesarean section. If you decide to do cesarean section, you will give a delivery. But if there is normal Doppler, the first choice to do induction of labor.
Okay, sir. Only in absent and reversed, we have to take her for C-section. Okay, sir.
If there is a static growth or there is abnormal ST3 or abnormal umbilical artery Doppler or abnormal middle cerebral artery Doppler or abnormal ductus venosus Doppler, here you will think about delivery. If everything is normal, induction of labor at 37 weeks. Let's see the mock exam. I will highlight all this.
Thank you, sir.
A woman is referred from the antenatal clinic with a reduced fetal movement at 29 weeks of gestation. The CTG or the computerized CTG is normal. With a short-term variability is 8, so it's fine. More than 5, it's fine. Ultrasound shows estimated fetal weight plotting below, you see, the 10th centile with reversed end diastolic flow in the umbilical artery. So I am here on the right side of the chart, absent or reversed. So I will think about what the umbilical artery Doppler and ductus venosus Doppler. Absent or reversed diastolic flow in the umbilical, middle cerebral artery Doppler and ductus venosus Doppler are normal. So I will consider delivery by 30 to 32 weeks of gestation.
32.
Even the ductus venosus is normal. Okay? She was given a course of steroid 2 weeks back for threatened preterm labor. Recommended management for this baby. What you will do for this woman?
C, sir. C.
C. Till DB becomes abnormal.
I will do daily ductus venosus Doppler and umbilical artery Doppler and deliver if the ductus venosus Doppler become abnormal, and even I will think to deliver here after 1 week. This is the evidence-based answer. The RTG wants you to answer like this. It's not a joke, or you are choosing what you think it's true. It should be an evidence-based answer. So there is no other option. This is the best answer here, according to the GTG of small for gestational age. You see what will be the explanation. The explanation is much more better than the question. The daily Doppler, please mute yourself or I mute all. Answer and put your mic on the mute again. I already removed your camera. You cannot open your camera. A daily Doppler and deliver if the ductus venosus Doppler is abnormal and even normal, I will deliver by 30 or consider delivery between 30 and 32 weeks of gestation. This is what he will tell you here in the explanation. But I highlighted a very nice point here. A fetal heart variation is the most useful predictor of the fetal well-being in small for gestational age if the short-term variability is 3 or less within 24 hours of delivery have been associated with a higher rate of metabolic acidemia, about 54% versus 10% if it is normal, and early neonatal death about 8.3% versus 4.5%. So if I don't have umbilical artery ductus venosus Doppler in my unit, or the fetal medicine unit is closed, I will depend on what? On the short-term variability of the CTG. So, while the CTG can be used to time the delivery, or when, or where, or at what time, the CTG can be used to time the delivery where the ductus venosus measurement are not available in your unit, or the fetal medicine is closed in the midnight. So depend on what? On the short-term variability, and it should be 3 or less to considered abnormal and deliver the baby. This is an RSOG trick and RSOG practice and an exam question. Let's do another question. For the following scenario, select the most appropriate next management option. A 29 years old attends the antenatal clinic for the first pregnancy. She smokes about 5 cigarettes per day. Her BMI is 27. You see, I am collecting factors here. The BMI is 27, and she smokes 5. Her blood pressure is 110. The urine analysis is negative for protein and the blood leukocyte. Her age is what? 29. So what I am saying
First pregnant, prime.
First pregnancy, primary.
What I am
Prime
searching
gravida.
for?
Prime gravida.
I am searching for what? I am searching
Factor
for
risk.
3 to collect
Minor risk.
to gain.
3 minor risk factor.
Excellent. So what I will collect of here? I will collect
Prime gravida,
smoking,
and smoker.
prime gravida, the woman is smoking, and the BMI between 25 and 30. So this is 3 minor. If we went back again to the screening chart, here, the screening chart, I will highlight the point here. You see, nulliparity, BMI between 25, she's 27, prime gravida, and smokes 5 cigarettes. Now I collect the 3. 1, 2, 3. So, evidence-based answer. This is the exam question. Okay? So, without continuing, this woman need uterine artery Doppler at 20 to 24 weeks gestation. She got 3 minor. She will have the price, or she will have one offer from us. If you got 3 minor, you will get uterine artery Doppler 20 to 24. Okay? The next scenario is a very nice one. An EMQ with a lot of options. And already I gave some clue for the exam question. I am not reading the option in the exam to save my time. Investigation or action to take in the next step. So he wants you to choose the most important ultrasound or investigation, or what will be the next step. Assume that your hospital, that you are in a hospital where the fetal medicine is available. So this is another clue. Each option can be used once or twice or as you want. So let's see the scenario. I already highlighted because we are not in the exam. I want you to pick the clues like I'm doing here. A woman has a gross scan as her previous baby was born below the 5th centile. So this is what? A high risk history. She is now 28 weeks of gestation. The gross scan in the obstetric unit shows the estimated fetal weight. So now he is going evidence-based with me. The woman have a high risk history, but he did the gross scan came on the 15th centile. Is this more for gestational age?
No.
No.
No. No. No.
Not with
No.
us. So I will continue monitoring
But
the
she
patient with what?
she will go for she needs follow-up. Serial follow-up.
Serial growth scan.
Excellent. Excellent. So this woman is not with us today. She will go with the serial gross scan or the gross scan every 3 to 4 weeks. Why? Because the criteria is not met. She is not IGR. So evidence-based answer. A high risk history, yes, because she have a history of baby lower than the 5th centile. I did a gross scan. The estimated fetal body weight came on the 5th centile, 15th centile. So it should be less than the 10th centile to be with us today. It is not small for gestational age. Let's see another scenario. A primary gravida is seen at 28 weeks of gestation. She has a gross scan due to semifundal height measurement below the 10th centile. So the patient came from this side of the chart. The semifundal height less than the 10th centile. So indicated to do what? The gross scan, the fetal biometry. It came below the 5th centile. So I will do what? The umbilical artery Doppler with a normal amniotic fluid and normal umbilical artery Doppler. What will be the evidence-based answer here?
Fortnightly Doppler and the growth scan.
Estimated fetal weight and umbilical artery Doppler fortnightly.
Wow, you are more than excellent. Now you are following my steps. You are answering with an evidence-based answer. So I will go with a gross scan, umbilical artery Doppler, and amniotic fluid assessment fortnightly. So there is no other answer rather than this. And this is the exam. This is how you should answer in the exam. There will be no two options, only one option, or you will do mistake. Okay?
So I have a question in the second question, so previous slide.
The previous slide?
Previous. Yeah. Yeah, so it said she had 3 minor risk factors, no, sir?
She has 3 minor.
3 minor risk factors.
Get the uterine artery
Yeah, but
Doppler 20 to
before,
24 weeks.
yeah, before uterine artery Doppler, we do the anomaly scan at 20 weeks, and if there is any echogenic focus in the bowel, then directly she goes to the major.
Excellent.
Then directly she goes, yeah.
Excellent.
So if that option is
now
there,
you are thinking evidence-based answer. You are bringing the patient here at 20 weeks. So you will do the anomaly scan and you will do the uterine artery Doppler. If post-normal, so this woman is a low risk, I will jump to the 3rd trimester. Reassessment in the 3rd trimester. Any abnormalities here, I will go for serial assessment from where? From 26 weeks of gestation. This is the evidence for the exam. Clear. I think we killed the small for gestational age. Let's move to another topic. I know that a lot of my friends did this with you before, but let's think different for the exam. It's a bullet or a shots for the exam to remember. Do you need a break? How many hours we now? It's 2 hours. I will continue with you till the morning. Do you need a break? I am very
No,
quick.
sir.
I can continue for 6 hours, no problem. Let's continue.
For brain.
Okay, just 5 minutes. 5 minutes. We will pray and come.
Okay, thank you.
The next topic is a very important exam question about the VTE prophylaxis, and I know my best friend Ghada Badran discussed with you. Just I will refresh your knowledge. There is an assessment, a risk assessment tool for VTE. The risk assessment tool is divided into 2 parts in the pregnancy, an antenatal assessment and after delivery, immediately in the delivery suite or after the woman got in the ward. So I have 2 risk assessment, the antenatal assessment and the postnatal assessment to be assessed on the delivery suite after delivery. What is the difference? How to prescribe a prophylactic dose? What is the indication of high dose? What is the high dose? So all these are exam tricks. So let's see how to classify a woman in the antenatal assessment as a high risk. If the woman have a previous DVT or VTE except the one who is related to a major surgery. So the woman have a fractured humerus or a fractured femur and she did a surgery and she have a DVT, this is a provoked. She's not here. She's here. So a single previous VDE related to major surgery, this is the only provoked DVT. Otherwise, it will be unprovoked. So if a woman have DVT before or VTE before, due to any cause except a surgery or a major surgery, she will be here. A high risk requires antenatal prophylaxis with low molecular weight heparin. He speaks here about prophylactic dose, and you need an expert with you. A pregnancy VTE specialist refer to the trust-nominated thrombosis in pregnancy expert team, a VTE specialist with you. So this one will be required an antenatal prophylaxis, and after that I will tell you she will have 6 weeks postnatal. Any woman with hospital admission, provoked surgery, high risk thrombophilia, but without VTE, because if with VTE, she will be indicated for high dose. Leave this now. Any comorbidity, and you will read it in details, but just take care that diabetes with nephropathy. Type 1 diabetes with nephropathy, not non-diabetic or GDM or without nephropathy. It should be with nephropathy to consider as intermediate risk. If you have intermediate risk, consider antenatal low molecular weight heparin from the start of pregnancy and offer it from 28 weeks of gestation. Any surgery procedure in pregnancy or ovarian hyperstimulation syndrome, this is a transient risk factor. It will be only antenatal in the first trimester. After that, you will collect one. Any one of these, you will have one. What will be the one? BMI 30. Take care. 30 is not included here, but included here in the postnatal assessment. So if the BMI is 30 in the antenatal, is nothing. In the postnatal, it worse 1. 30 antenatal, no, the woman is mobile. More than 30, she will score 1. Age 35, and here is the same. More than 35 and more than 35. Parity 3 or more and parity 3 or more. Smoker, varicose vein, current preeclampsia, immobility, injury, paraplegia, scores 1 only. Family history of unprovoked or estrogen related in the first degree, scores 1. Low risk thrombophilia, which is the heterogeneous factor B, scores 1. High risk thrombophilia, it will be here, intermediate. Plus family history, this is an exam trick, I will tell you now. Or plus VTE, this is an exam trick. Low risk thrombophilia scores 1. Twins, IVF scores 1. If you collect 4, offer antenatal from booking. If you collect 3, offer from 28. 2, so antenatal, early ambulation and hydration, no prophylaxis. Just mobilization and hydration. No low molecular weight heparin. If 2, she will not get antenatal, but she will have 10 days postnatal. There is a tricks. What will be the tricks? A low-risk woman in the antenatal assessment may be a very high-risk woman in the postnatal assessment. And this trick always coming in the exam. A woman with heterogeneous factor V with a family history scores 2 in the antenatal. Look here, it is high risk for 6 weeks in the postnatal because 2 things came together. A low risk thrombophilia plus family history. So nothing antenatal, avoid laziness and mobilization and avoid hydration, but 6 weeks postnatal. This is the first trick. So provoked or unprovoked, intermediate risk or high risk, collect for
Dr.
and
Hany?
get antenatal. Please.
Dr. Hany, can I just, relating to this only, I wanted a clarification.
Just give me time to finish the short and I will clarify everything. Just give me all, I will give all the tricks. So, a low risk thrombophilia, heterogeneous factor V plus, family history, antenatal scores 2, but postnatal high risk for 6 weeks. And this is a trick from the RSOG. And it will come in the exam. Any previous VTE, she will be high risk. Any antenatal prophylaxis, she will be for 6 weeks, except the antiphospholipid syndrome. It has a special criteria. It should be reassessed again after delivery. It can give for 3 or 5 days, but it will not be for 6 weeks. So any antenatal low molecular weight heparin due to the VTE assessment, not for recurrent abortion, due to the VTE assessment will be 6 weeks. High risk thrombophilia, low risk, high risk thrombophilia, or low risk from plus family history. So scores 2 in the antenatal, but high risk in the postnatal. Emergency cesarean section in labor scores 2 for 10 days. BMI 40 or more scores 2. Admission or readmission in the PPROM also for 10 days, more than 3 days. Any surgical procedure except perineal repair, appendectomy, or any surgery, also for 10 days. Any medical morbidity for 10 days, except if you have persistent causes. You will continue or consider extending it for 6 weeks. After that, a risk assessment. Collect 2 and get 10 days. Lesser than 2, not 3. In the postnatal, only 2. Only 2. You will put the patient on 10 days low molecular weight heparin. The problem is that we are missing some of the 2. As I told you, the BMI 30 scores 1, but 40 scores 2. Elective cesarean section scores 1, but emergency cesarean section scores 2. Family history alone scores 1, and low risk thrombophilia scores 1. But if the patient have both, it will be here. But if one only, it will be scores 1. Infection, paraplegia, current preeclampsia, twins, always forgetting. Preterm labor, always missed. Stillbirth, mid-cavitary or rotational. It's wrong here. It is written wrong in the chart. It is mid-cavitary or rotational. Why? Because painful, traumatic, and the woman will have restricted mobility after delivery. So, gives you scores after delivery. So, mid-cavitary forceps or rotational scores 1. Prolonged labor and postpartum hemorrhage more than 1 liter scores 1. Actually, this is the exam tricks. So, the risk assessment will be in the antenatal and in the postnatal. The dose is a prophylactic dose, and the prophylactic dose will be according to the weight, and you should know this by heart. I will not speak about the prophylactic dose. And after that, the transient and the pre-existing factors, already I told you about the pre-existing factors before and after. I need this chart. Also, this is a risk assessment. Already about how to know. Any previous VTE alone, unprovoked, without any surgery, score 4 gives you antenatal and 6 weeks postnatal. The intermediate, 3. Provoked VTE with surgery, 3. Antiphospholipid syndrome. The woman has systemic lupus erythematosus, cancer, heart failure, active systemic lupus erythematosus, unknown high-risk thrombophilia, inflammatory bowel disease, diabetes with morbidity. Antiphospholipid syndrome is antenatal for recurrent abortion. Low molecular weight heparin plus aspirin have a special criteria. If the woman had score 1 or 2, you will give score in the antenatal risk assessment. Cesarean section 2, emergency, elective 1. BMI postnatal, take care, 30 and 40, 1 or 2. Ovarian hyperstimulation is a transient risk factor. It will be in the first trimester only. What I want to get is the last exam trick. This chart is a killer chart. If you don't understand this chart, you will be lost in the exam. This chart is very important. Why? Because it gives you the indication for high dose, the indication for what to do and how to do in the exam. A summary of the guideline for thromboprophylaxis in a woman with previous VTE and or thrombophilia. Actually, there is 3 indications to give high dose. The 3 indications for high dose is a previous VTE plus high-risk thrombophilia, a previous VTE plus antiphospholipid syndrome, or recurrent VTE. You will prescribe a high-dose antenatal and 6 weeks postnatal. This is an exam trick. What is the high dose? High dose, either 50 or 75 or full treatment dose, not prophylactic dose. There is difference between the prophylactic dose and the treatment dose and the high dose. The prophylactic dose assessment, risk assessment, prophylaxis from having DVT in pregnancy. The treatment dose, the woman already have a VTE and you want to treat her. And the high dose is 50 or 75% or full treatment dose. What is the indication of high dose? It's here. A previous VTE on long-term anticoagulant, a very high-risk woman with antithrombin deficiency, high-risk thrombophilia, antiphospholipid syndrome with VTE. So, recurrent VTE, a previous VTE, or a previous VTE plus antiphospholipid syndrome in the question, a previous VTE plus antiphospholipid syndrome, recommend antenatal high dose and 6 weeks postnatal. And the woman require a specialist in expert, a VTE expert with you. So what is the indication of high dose? Recurrent VTE on oral anticoagulant or warfarin or NOAC or anything. She have a prosthetic valve or she have a VTE before and she have recurrent and she is on anticoagulant. Actually, this is a bridging. I will speak about the bridging. Or the woman have previous VTE plus antithrombin deficiency or plus antiphospholipid syndrome. This is the indication for high dose. And you will answer like this in the exam. What is the high-risk patient? A patient with previous VTE, except the provoked. So this one was the first one in the chart. The unprovoked VTE. You will give what? You will give antenatal prophylactic, low molecular weight heparin, and 6 weeks postnatal. Not full or high dose. She have a history only of VTE, not recurrent VTE, not an oral anticoagulant. If she have VTE plus antithrombin deficiency, high risk thrombophilia, or antiphospholipid syndrome, this will be indication for high dose antenatal and 6 weeks postnatal. Alone VTE, unprovoked, so prophylactic. Take care. There is different here. This is the first one in the chart. This is the indicated one to give a high dose. After that, the intermediate risk and the low risk. The intermediate risk, asymptomatic high risk thrombophilia, you will consider antenatal or offer from 28 weeks. Asymptomatic high risk thrombophilia, homogeneous factor V is a high risk, heterogeneous or gene mutation is a low risk, protein C or protein S deficiency is a high risk, single previous VTE associated with major surgery. So this is a provoked one. It's intermediate risk. Consider antenatal or offer from prophylactic, sure, from 28 weeks of gestation. And you will go for 6 weeks postnatal. Okay? Until now we are fine. A low risk thrombophilia, as I told you, scores 1 in antenatal. With a family history, it will be for 6 weeks high risk. Consider as a risk factor, so scores 1 in the antenatal risk assessment, and give 10 days if there is another risk factor, except the family history. If she have a low risk thrombophilia plus family history, she will be in the 6 weeks postnatal. Does this make sense? So,
Dr. Hany, one question there, please.
Sure.
Slide.
Please repeat the question. I couldn't hear you.
No, I'm asking that antithrombin deficiency, we said that if it is associated with venous thromboembolism, it becomes a very high risk.
Just listen for the next slide. I will give you this in the
factor,
next slide.
And we have to give.
Yes. Just wait for this slide. This indication, what is the indication for high dose? I told you.
High dose.
Just wait for a second, please. I will tell you now.
I'm asking without.
Just a second, Dr. Asim. Just a second. I will repeat this now because this is an exam question, even it came with me. So, indication for high dose. I told you there is a prophylactic dose starting from the unprovoked. After that, the intermediate risk. This is called prophylactic dose according to the patient weight, either less than 50, more than 50, or according to the patient weight, you will adjust the dose. The high dose will be how to think or how to give. What indication or what is the indication for high dose? A woman with a previous VTE with high risk thrombophilia or antiphospholipid syndrome. So you need a history of VTE plus antiphospholipid syndrome and a history of VTE plus antithrombin deficiency to prescribe a high dose antenatal and 6 weeks postnatal. And the third indication is recurrent VTE require a higher dose of low molecular weight heparin. This is the 3 indication only to offer high dose antenatal and 6 weeks. What is the high dose? The high dose will be 50 or 75 or full treatment dose antenatal and 6 weeks postnatal until the woman go back again for her oral anticoagulant, which is the bridging. If you have no query, I will speak about the bridging.
So I wanted to ask one thing here. Like just antithrombin deficiency without previous VTE will not be high risk, sir. It will not be very high risk.
No, antithrombin alone
because in the chart
it will be very high risk.
No, without
because in that chart he has just given antithrombin before this in that chart.
Just I will tell you.
Yeah.
Antithrombin alone.
Risk
thrombophilia. It will be here, intermediate risk factor, and you will speak about what? About the antenatal prophylactic or offer from what? From 28. But it should be without VTE. If she have VTE, it will be outside the prophylaxis at all. It will be, this is called obstetric thromboprophylaxis. It will be a high dose, a previous VTE plus antiphospholipid, a previous VTE plus antithrombin or high risk thrombophilia. or recurrent VTE. You will be here. Indication for very high risk. Alone, it will be here. Asymptomatic thrombophilia, but high risk thrombophilia. Homogeneous
Okay, sir.
factor
And
B,
my
it will be
second,
here. Heterogeneous, it will be here. Okay?
yeah. So second thing I wanted to ask is high dose is given only in the antenatal period or even in the 6 weeks later, which we give in postnatal, that will also be high dose.
Let's read here. It will be 6 weeks postnatal or until return to the anticoagulant. Okay, let's speak about the pregnancy, about the bridging, because the bridging always coming in the exam. A woman already taking warfarin, the new NICE guideline for a woman with a pre-existing disease, taking warfarin. What will be the indication? When to stop warfarin, when to bridge, and how to do cesarean section, and how to bring the woman back to warfarin. Who knows? The first one, I will give him the mic. Who read? Who know about this? 10 days for the exam. What you will do? Okay. A woman taking warfarin, the new NICE guideline for intrapartum care with a woman with pre-existing disease stated that it should be stopped at 36 weeks or 2 weeks from elective delivery. So warfarin should be stopped, not 5 days. This is for gynae surgery. The new NICE guideline stated that warfarin can be given in pregnancy for a woman with prosthetic valve until 36 weeks or 2 weeks from elective birth. So I will stop it at 36 weeks of gestation. Then I will put the woman on a low molecular weight heparin. Why? To decrease the risk. I have 2 risks here. The risk of developing VTE or DVT in pregnancy and the risk of bleeding in surgery, in cesarean section. If I stop the warfarin, the woman will get pulmonary embolism and will get DVT. If I continue the warfarin, the woman will bleed to death from your own table. So what I will do, I need the bridging here. So I will stop warfarin at which gestational age? 36 weeks or 2 weeks from the elective birth. So I will deliver the patient at 38, I will stop at 36. Then I will bridge the woman for low molecular weight heparin or unfractionated heparin in high-risk woman. Then I will monitor the patient until, if she is taking prophylactic dose, until 12 hours from cesarean section. If she is taking treatment dose, it will be stopped at 24 hours from the cesarean section. Then I will do the cesarean section within this 12 or 24 hours. Prophylactic dose, stop before 12, before surgery. Therapeutic dose, stop 24 hours before surgery. Then do the cesarean section, put epidural, then go back for the low molecular weight heparin 4 to 6 hours after the surgery until you restart warfarin. For what? The NICE guideline again for intrapartum care with a pre-existing woman states that you cannot start warfarin unless 7 days after the surgery. So I will continue the low molecular weight heparin with the woman after surgery until 7 days. Then I will add the warfarin. The warfarin will take time to start. I will be guided by the INR. It should be kept between 2 and 3 or 3 and 4 according to the risk assessment and the VTE specialist. And after that, if I reach the INR, I stop the low molecular weight heparin and continue with the woman with her warfarin. Does this make sense? Clear? Or I will repeat?
Yes, sir.
Okay. Happy with the bridging?
Clear, sir.
Not ask again about the bridge.
That INR checking we do daily.
Can you repeat again?
I will repeat once more, but stay focused. I know the time is late for some countries, but please refresh yourself, take some coffee, and stay focused with me. Actually, I will clear a lot of concepts for you. A woman taking warfarin because of a prosthetic valve in pregnancy, and this is the only indication for warfarin in pregnancy. I will stop it at 36 weeks of gestation or 2 weeks from elective birth. What I will do, I have 2 risks here. The risk of bleeding in the theater and the risk of getting VTE for this woman, a shower imply. So I need the bridging here. So I will stop warfarin at 36 weeks or 2 weeks from the elective birth. Then I will shift for the woman, for the low molecular weight heparin or the unfractionated heparin according to the risk assessment. If she is very high risk or intermediate risk or a low risk, then I will stop the low molecular weight heparin according to the dose. If she is taking therapeutic dose or prophylactic dose, therapeutic dose, stop it 24 hours. Prophylactic dose, stop it 12 hours before the surgery. Then do your safe surgery. Enhanced recovery program, elastic stocking, all the measures to decrease the intraoperative, shortening, avoid drain, shortening of the time, avoid draining, avoid extra manipulation. All this will be helping in reducing the VTE. Then, after delivery, 4 to 6 apart from the epidural or 4 to 6 hours apart from the surgery, you will start the low molecular weight heparin. And the NICE guideline again states, if you read it, it will give you a clear concept that you will start warfarin again after 1 week because of the risk of bleeding and postpartum hemorrhage. So you will continue the low molecular weight heparin for 1 week. Then you will add the warfarin, which need time to start. So you will keep the woman on pause, targeting by the INR with the VTE specialist, either 2 to 3 or 3 to 4 according to the woman risk assessment. Once you reach the INR, you will stop the low molecular weight heparin, continue with warfarin. I will be happy if you got this from me today, because this is a very important point.
Dr. Hany, this bridging therapy is only for mechanical valve on valve?
What is,
or is there any other indication?
The only
No, I'm asking, is there any other indication or only this?
indication to give and you need bridging is the prosthetic valve. And this woman who is the one only take warfarin in pregnancy. Does this make sense?
Yes, thank you.
Let's move.
Thank you, Dr. Hany.
Sir, therapeutic.
I would
Sir,
like
I
to
have a
ask
doubt.
regarding this scenario of the woman who is having the prosthetic valve and she is having a history of a previous VTE and she is getting pregnant. We will give her also the high therapeutic, prophylactic dose of low molecular weight heparin since she got pregnant. Plus, we will continue after bridging on the high prophylactic dose.
No, Dr. Rabab.
Am I correct?
You mixed what I said, Dr. Rabab. You said that from your talk, the woman have VTE before taking warfarin. With a prosthetic valve, you will continue warfarin. This is the only indication to give warfarin in pregnancy. And you will stop it at 36 weeks of gestation.
Sir, I have a doubt.
The period before warfarin, she will be on high molecular weight, like the period just she got pregnant till before 6 weeks. She will be on high dose of low molecular weight heparin.
My dear, you didn't get the point. The woman already have a prosthetic valve and she is on warfarin. You cannot stop warfarin. This is the only indication to give warfarin in pregnancy. So you will continue warfarin until 36 weeks. Then you will shift the woman to the low molecular weight heparin, either high dose or low molecular weight dose. It will be a high dose because actually she's a high risk woman.
Okay.
Do the bridging.
I mean through the
back again on the high dose until she continues the warfarin. This is the bridging.
Okay. Even during the period of organogenesis, she will have the warfarin.
That's what I'm telling you. This is the only indication to give warfarin in pregnancy. If the woman has, okay.
Okay. Got it, doctor.
Sir, while using
Thank
this
you.
LMWH, in case of metallic valve, we use bridging LMWH that is in therapeutic dose. So should we start it 6 to 8 hours post delivery and post cesarean also, sir? 6 to 8 hours?
You will use the unfractionated heparin in a high risk patient until 6 hours, and you will start it after 6 hours, my dear. The high dose cannot be started early. you will stop it 24 hours, and you can bridge the patient for the unfractionated heparin because it's a short acting. Don't go deep in the bridging because you will confuse yourself. I am giving you what you need.
Okay, sir. Thank you, sir. Got this point. Thank you so much, sir.
So, and I've read in one question that if therapeutic valve, except for bifid aortic valve, is it true, sir? Like for aortic valve, we will not give warfarin.
Have prosthetic valve during pregnancy, this is the only indication to give warfarin. Otherwise, no way, no chances to give warfarin. Okay.
Okay, and then we change from warfarin to low molecular weight heparin at 36 weeks.
Because the WAC is contraindicated in pregnancy. This is for gynae surgery. I will post the chart. You can have a look on it. This is for NOAC or the non-vitamin K oral anticoagulant or the rivaroxaban. This is also have a bridging, but not like the warfarin, the most common one, because this is not indicated in pregnancy. Okay? This will be for the gynae surgery. You can read it. The same idea, but you will stop it in minor surgery 24 hours. In major surgery like us, you will stop it 48 hours before the surgery, and you will go for the surgery. Even some woman will need no low molecular weight heparin if she's taking NOAC. Not in pregnancy. I told you, NOAC or non-oral or non-oral anticoagulant or non-vitamin K oral anticoagulant like the rivaroxaban is not for a pregnant woman, for a gynae surgery. And you will assess the woman. If the minor surgery, you will stop it 24 hours. If a major surgery, 48 hours, and you will go for the surgery, and you can start the low molecular weight heparin 6 to 12 hours after the surgery. In the guidelines, they said 6 hours, 4 to 6 hours after epidural. Then you can give NOAC at the night of the surgery. 12 to 24 hours from the last heparin dose or low molecular weight heparin. This is for gynae surgery, not for the obstetric or the CS. Okay?
Hany, there is room for creatinine.
So can I ask one thing? One
Yes.
question?
Sana first asks.
So it is, yeah, so it is, so you had said, no, in the first chart that it is more than 30, it is not 30. But in appendix 6, in the lower down, it is written more than or equal to 30 is equal to 1.
I didn't get the question, Dr. Johanna.
In the antenatal, BMI.
BMI antenatal more than 30, postnatal 30, yes. Take care only about the tricks for the antenatal risk assessment.
Actually, in that it is written more than 30, and in appendix 3, lower down, it is written more than or equal to.
More than 30.
So in next chart, it is written more than or equal to 30.
In the next chart?
In appendix 3. Appendix 3, yeah. Appendix 3. Yeah, below it's just lower down. What you are showing, no, in very small letters it is written. More than or equal to 30 is 1. Below, even below this, probably your, it's courses is written, it's coming here.
No, is the difference between antenatal and the postnatal?
No, but these are the risk factors for VT, no, pre-existing risk factors.
Yes.
It's written BMI more than or equal to 30 is 1 and more than or equal to 40 is 2.
Sorry, where is it?
So even below that, I think where your this MRCOG courses is coming, no, I think it's below that.
Last line, sir. Very last line.
It is at the bottom of this chart.
This is postpartum.
It's at the bottom of this chart. The last
bottom
line.
of this chart.
Take care, I told you. In the postnatal, 30 or more scores 1 and 40 or more scores 2. I told you this in the assessment. In the antenatal, more than 30, my dear. Okay?
No, so this chart is for the postnatal. This is the pre-existing.
This is, my dear, for the postpartum assessment. Postpartum, in the postpartum assessment, 30 or more. Antenatal, 30.
Okay.
So in antenatal, BMI of 40 is score 1 only?
No, 42.
No, it's 2, no?
40
So both
means 2,
antenatal
my
and
friend.
postnatal.
40 alone will put you in the intermediate risk. Okay?
I kept on thinking it's a misprint. And I was thinking 30 is also included in it.
Okay, no problem. Just follow
Doctor.
the guideline. Evidence-based answer. Okay? Let's move because I have a lot to tell you today. Investigation and
Doctor, I
management
have
of
a
pulmonary
question.
embolism, and pulmonary embolism is the second guideline for the VTE, and you should know this chart by heart. Once you suspect, you will do the assessment. Once you suspect, you will do the investigation. Once you suspect pulmonary embolism, you will start low molecular weight heparin. This chart should be like your name. Suspected pulmonary embolism by the clinical assessment. Chest X-ray is needed. ECG is needed. Full blood count, urea and electrolyte liver function, and start the low molecular weight heparin. If there is symptoms and signs of DVT, the woman have a tender cough, there is a swollen leg, so you will do a compression duplex. What is the compression duplex? You will press the probe on the woman cough. If it is collapsed or if the vein compressed, so there is no thrombosis. If it is compressed, it is non-compressible, so there is a thrombosed vein. So a compression duplex ultrasound, find DVT or confirm there is DVT, you will continue the low molecular weight heparin in the therapeutic dose. If no signs of DVT, you will go for just chest X-ray assessment. Normal VQ scan. Any abnormal finding, CTBA. So you should know the stepwise management. Suspicion, clinical assessment, chest X-ray, ECG, on full investigation, full blood count, urea electrolyte and liver function, and start low molecular weight heparin. There is suspicion of DVT, do compression duplex. No suspicion of DVT, chest X-ray. Normal, VQ scan. Abnormal, CTPA. Pulmonary embolism, confirm it, continue low molecular weight heparin on a therapeutic dose, not confirm it. So the CTPA or the VQ scan does not find anything, and you have suspicion still, so continue. So continue. Still you have suspicion. If the clinical suspicion of pulmonary embolism is low, stop, because all the investigation normal and your suspicion is low. So stop and consider another diagnosis. But if you still clinical suspicion is high, even all normal, continue. Continue. So if clinical suspicion is high, consider alternative and continue low molecular weight. All these are exam tricks. All these are exam questions. Okay? Let's do a mock exam on the VTE only. An option, I will not read the option at all. As I told you, I will go for the heading. A pregnant woman came. A pregnant woman came for booking. She gave history of DVT. A very highlighted point. History of DVT. Investigated high risk thrombophilia will be
Very high dose.
I don't
High dose.
High dose of low molecular weight heparin antenatally and postnatally.
Antenatally and 6 week postnatal.
excellent. So this is one of the indication to give high dose antenatal and 6 weeks postnatal. So now you got my point. A previous VTE plus high risk thrombophilia or antiphospholipid syndrome, you will be in the high risk group. So this woman will be a high dose. This is one of the indication of high dose low molecular weight heparin antenatal and 6 weeks postnatal. I think I
Postpartum also high dose or
This
prophylactic
patient
dose, sir?
take therapeutic or diagnostic? Therapeutic or prophylactic? This patient.
High dose, no prophylaxis here, no sir. High dose. This is one of the indication of high dose. The high dose will be 50 or 75 or full treatment dose. So she will be either to have 50% of the therapeutic dose or 75% of the therapeutic dose or the therapeutic dose itself. This is called the high dose. Okay? I missed one question here.
Okay, thank you.
Delivered baby by normal vaginal delivery. She is smoker and have gross varicose veins. So 2 risk in antenatal or in antenatal nothing. In postnatal because she delivered 2 risk factors. She will have 10 days postpartum.
Postnatal
Elastic stocking.
10 days postnatal.
Excellent. So this woman will take 10 days postnatal only. Antenatal, nothing. And question number 2, already we know that the woman have a history of DVT plus high risk thrombophilia, antithrombin deficiency, or antiphospholipid, or recurrent VTE. This is indication for high dose. Okay? Question number 3. A gravid 2, 35 years, known with chronic hypertension. A chronic hypertension scores or no? A chronic hypertension give you a score? No.
Nothing.
It should be what?
No. 4, 1,
No, 0.
0. 0.
Preeclampsia is scored.
Excellent. It should be pretenoric. It should be preeclampsia. So chronic hypertension alone, nothing. Now pretenoric.
Now it is a superimposed pre.
It's scores.
So we can give 1 to this now.
Station is 32. How many factors here?
Twins, 3 factors. BMI, twins, preeclampsia.
Admitted 2, antenatal 3, twins 4. So
It's 4.
I will start now. Low molecular weight heparin and 6 weeks postpartum.
And
this is 4 risk factor at
Dr. Hany, admit 3 or 4.
Risk factor to give in admission. But now she have already 4 risk factors. And after discharge, she will have 3. And now she is more than 28 weeks. So low molecular weight heparin from now 6 weeks postnatal. Another question.
Sir, admission is scored as 1, sir.
Score, it's a transient risk factor. More than 3, it will score 1. More than 3 days, score 1.
more than 3 days, yes?
During admission, it's intermediate. So if you admit patient without any other score, you will give her in hospital because she already admitted. And this is a transient risk factor. Any admission in pregnancy without any other score, so give during admission only. After that, no. Does this make sense? Is this point?
So in the previous question,
Why
you gave...
postpartum 6 weeks?
No, in previous question, you gave score 1 for admission also. That's how it became 4.
No, it will be during admission only. Because she is admitted, it gives you a score more than 3 days. But if the woman discharged and she is no risk, antenatal, no other risk factors, so admission will be only during the admission period. Like the transient risk factor of ovarian hyperstimulation syndrome. Okay? For the scenario below, select the most appropriate management option. A 28 years old woman pregnant for the first time. She has previously undergone thrombophilia screening due to family history of VTE, and she is known to have protein S. So, what you will do?
Is high risk, no? Protein S is in high risk. So we will consider low molecular one is that is
local expert.
Excellent. So
Yes.
this woman,
Yes, sir.
she has a family
Refer to local expert.
high risk
Postnatal 6
high
weeks.
risk thrombophilia. So this woman will have an expert, and she will take low molecular weight heparin. What?
Postnatal 6 weeks, sir.
6 weeks.
6 weeks. 6 weeks.
6 weeks. Excellent. Refer to a local expert, but advise at minimum 6 weeks postnatal low molecular weight heparin. Why? Woman with asymptomatic antithrombin, protein C or protein S should be referred to local expert. Antenatal prophylaxis considered and should be recommended for 6 weeks postnatal prophylaxis. So this will be the answer.
Repeat that. We couldn't hear your voice.
The woman have no voice. The woman have a thrombophilia plus family history, asymptomatic thrombophilia or protein C or protein S plus a family history. This is an indication to refer to expert and 6 weeks postpartum. You see here, this chart is very important. Asymptomatic high risk thrombophilia or protein C or protein S should be referred for a local expert, consider antenatal and recommend postnatal prophylaxis. This is the question here. Postnatal low molecular weight heparin prophylactic for 6 weeks. Okay, that's why I keep persisting on this chart. It's a very important chart for the exam. This is an easy question also. A 27 nulliparous patient has uncomplicated elective cesarean section and she smokes, so score 1 and 1. So elective scores 1 and smokes
10 days. Please, sir.
10 days.
10 days
postnatal.
postnatal.
So she will have
10
10
days
days.
postnatal.
Post-
3 risk factors postnatally, 10 days.
What I will tell you now is a very important point for the exam. Stay focused for me. Don't lose your conscious, because there is a lot of exam question will come from this slide, and you will know as you will never read it before. A postpartum hemorrhage, it's a flow chart with a stepwise manner. You should know it by heart. A major obstetric hemorrhage, more than 1 liter, call for help. Who will come? Senior midwife, senior obstetrician, anesthesia, hematology, blood bank, and laboratory. What you will do? Start resuscitation, airway, breathing, circulation, and the fluid management. Leave the fluid management now, because I will speak it about in details. The fluid management will be 2 liter crystalloid and 1.5 liter colloid, and blood transfusion, O negative, K negative blood, until the cross-matched blood is there. After that, you will give the deficient according to the parameter. So I will speak about this within few seconds. After that, you will go in both sides. You will investigate, collect blood, put a catheter, put ECG monitoring, do a hemoglobin bedside, the blood product, consider central and arterial lines, and start the short or the new short, and start the medical treatment, both observation and monitoring, and start the medical treatment. The first step will be wrapping the uterus or mechanical massage, empty the bladder, oxytocin, 5 international unit IV, ergometrin 0.5 slow IV or IM, then oxytocin infusion, stepwise. So go step by step. Then carboprost 0.5 every 15 minutes for 8 doses. Then you can consider during cesarean section 2 ampoule carboprost 0.5 intramyometrial and 4 misoprostol tablet sublingually and tranexamic acid. A stepwise manner. It will come in the exam like what we told. A stepwise manner. If all this failed and the woman refused surgery, so think about recombinant factor 7. It's under trial, but can be put here. The guideline said that if the woman failed all medical treatment and refused surgery, so think about the recombinant factor 7. The first step in the theater, you will examine the woman under general anesthesia. Is the uterus contracted or no? Examination under general anesthesia. Is there any tear or no? Then, if still atonic postpartum hemorrhage, you will start by the intrauterine balloon tamponade, which is the Beckley balloon. The first surgical maneuver is Beckley balloon. The first thing to do in the theater is examination under general anesthesia. A safe doctor will do this. Don't rush. Don't jump. A step by step. So in theater, examination under general anesthesia. After that, the first maneuver will be intrauterine balloon. Failed, here you will go for the P-Lens suture or interventional radiology. If this failed, you will go for a stepwise uterine artery ligation by bilateral internal iliac ligation and hysterectomy if a second consultant is here. So you need 2 consultants to remove the uterus. Stepwise uterine artery ligation will be 1 uterine artery, post uterine artery, low uterine arteries, and anastomosis or high ligation of the anastomosis. This is called a stepwise. You can review this in the guideline. So this is the tricks. A stepwise management. Both recombinant factor 7 here if the woman refused to go for surgery. The first thing is in the theater to do examination under general anesthesia. The first surgical maneuver will be the intrauterine balloon. A stepwise manner. Pay attention again. The fluid therapy is very important. 2 liter crystalloid, then 1.5 liter colloid, then O negative, K negative until across matched blood is there. The fresh frozen plasma is very confusing. And I will give you the secret today. If the woman platelet less than 75, I will give 1 pool of platelet. If the woman fibrinogen less than 2, I will give 2 pools of cryoprecipitate. So all these are exam questions. Let's go for the fresh frozen plasma. The fresh frozen plasma should be guided by the bleeding is still continuous and the lab is there. The hemostatic test available in your hospital or no. So read with me as you never read it before. So the fresh frozen plasma should be guided by that the labs or the hemostatic test is there in your hospital or no. And the hemorrhage is continuous is no. Continuous hemorrhage and you have lab or no. If the prothrombin time or the PPT, the activated partial thromboplastin time are prolonged and hemorrhage is going, give the specific dose. If you have the lab. If you don't have the lab, so you are alone and the lab technician is not there and no lab available, and you give 4 units of blood, so you will give 4 units of fresh frozen plasma. This is the massive blood transfusion protocol. If hemorrhage continue after 4 units of blood and you don't have hemostatic test in your hospital, the PT and PTT is not available, so massive blood transfusion protocol. 4 units to 4 units. If the bleeding is going and you have the lab, and the lab is prolonged but less than 1.5 multiple of mean of normal, so give the specific dose. If it is more than this, you will give the higher dose. Let's move a little bit. What is the fresh frozen plasma rules? When to give, what to give, and how to give. If the bleeding is going, if hemorrhage is still going, and you have the BTT in your lab and are prolonged and available, but less than 1.5 normal, so you will give 12 to 25. So if the normal level of the value is say 30 and the result came 50, so it is 1.5 higher than normal. So if it's still between 30 and 45, I will give the specific dose. If it is more than 50, I will give the higher dose. Excess than 50. So if the labs are there and more than 1.5 normal, I will give fresh frozen plasma in excess of 15 milliliter per kg. Does this make sense? Or no? A very valid point for the exam. Is this point
Can you
clear?
repeat this slide again, please? Just repeat this one again, please.
Okay. Okay. I have a rules. I have a rules to guide me when to give a fresh frozen plasma. The bleeding should be continuous and the lab is available. If the lab available, I will go for a specific dose. If the lab is not available and hemorrhage is continuous after 4 units, I will follow the massive blood transfusion because I don't have hemostatic test available. So 4 to 4, this is finished. The problem is here. If I have labs in my hospital and the lab called me and he said, Dr. Hany, the lab is 1.5 times normal. It is prolonged and I will give fresh frozen plasma in the specific dose between 12 and 25. Why? Because the labs are prolonged but not so high. It is still less than 1.5 normal. If the PT and PTT ratio is 30, normal, and you got result up to 45, so this is called 1.5 normal. If the limit is here, he will tell you the labs came prolonged, but less than 1.5 times normal. So you will give 12 to 15. If it exceeds this limit, 1.5 times normal, so double the normal. This means that the labs became double the normal and hemorrhage is going, so you will give more in excess to 15. This will be written in the details of the guideline. And actually, the RCOG loves these tricks. So more than 1.5 normal, give more than 15 milliliter per kg. Between normal and 1.5 times normal, give the specific dose, 12 to 15. You have no labs in your hospital, 4 to 4. And this is called the massive blood transfusion protocol. Clear?
Yes, thank you.
Thank you very much.
Clear.
I know that a lot of us don't know this, so I am keep persisting or insisting to clarify each single point for the exam. So I am making the difficult scenario for the exam for you. So you will be higher than the level of the candidate. Any questions so far? Maternal collapse is a new GTG and you will find a lot of questions. Maternal collapse is a killing for the exam. If you don't know how to manage maternal collapse, you will be unsafe, doctor. So maternal collapse is a new GTG and you should know it by heart. I will refresh your knowledge in another way. The causes of maternal collapse. What is the most common cause of collapse?
Hemorrhage. 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 Hemorrhage.
Did you read the new
Venous
guideline?
thromboembolism.
Venous thromboembolism.
They removed epilepsy. It was a mistake in the old guideline. In the new guideline, they clarify this down. Epilepsy. They removed hemorrhage. The most common cause of collapse is epilepsy. And see the details of the guideline again. It was a mistake in the old guideline. They removed it in the new guideline because I am reading in the specific details long time ago. So it was a mistake and removed it. The common cause of collapse is epilepsy, not hemorrhage. Review the guideline again, you will find what I am saying. The causes of maternal collapse is 4H and 4T, and you know, and 2 in pregnancy, and they forget about the hypoglycemia. So remember the hypoglycemia. 4H and 4T and 2 in pregnancy. This is the 4H and 4T and 2 in pregnancy, which is the eclampsia and preeclampsia. And again, they forget about the hypoglycemia. So put the hypoglycemia here. So it's a cause for reversible cause. They mentioned it in the guideline, but they forget it here in the chart. So 5H actually, and 4T and 2 in pregnancy, which is eclampsia and preeclampsia. So these are an exam questions. The flow chart is very important. How to manage or the algorithm of collapse is very important. Your safety is an issue. A collapsed woman on a building, check safety before you go, or you will be another collapsed doctor besides a woman. So safety is a very important. Patient safety and your safety. So a collapsed building, a car accident, check your safety first, or you will do nothing. If you became collapsed or traumatized by the car, by the RTA, so you need 2 to resuscitate or 4 to resuscitate. So safety is very important. And after that, simultaneous response. Assess the woman response. If the patient is not responding, so shout for help. If she is responding, so put her in the recovery position, assess the blood pressure, respiration, and everything, and see the mood chart and see the cause of the collapse. But she is responding and she is fine. So she is not our issue now. Put her in the recovery position. Left lateral tilt 15 degree. Why 15 degree? Why he mentioned 15 degree in the guideline? Because
Pregnancy, later.
Yes. Why? Why?
To avoid aortocaval compression.
It will give you effective compression. It will relieve the aortocaval compression. That's why it is mentioned by it. The most common cause of collapse is epilepsy, my dear. They written it by mistake in the old guideline, and they removed it in the new guideline. Okay, so the left lateral tilt will be 15 degree. Why? Because it will give you effective resuscitation, effective cardiopulmonary compression, and remove the aortocaval compression. So improve the venous retain, improve the cardiac output. That's why I'm telling you the left lateral tilt is very important. After that, call for help again. You see? Call for help. Shout for help and call the resuscitation team. Then open the airway. Check the obstruction, head tilt, the chin lift, and clear if there is any secretion. Look, listen, and feel. If you attend the life support in the Gulf City, you will know this by heart, because this is a basic knowledge. You should know it by heart. So look, listen, and feel for what? Look for the chest rise for breathing, listen for the breath sound, and feel for air coming. It will take only few seconds, even 5 seconds, not 10 seconds, to know if the woman is breathing or no. If the woman is breathing, Breathing normally, turn in the recovery position, check or call the help is coming or no, assess the breathing, the pulse, the blood pressure, the nose short, and see the cause. If the woman is not breathing, start the CPR. So, a new recommendation, a very important point. I will not check the pulse. Look, listen and feel. Look for chest movement, listen for the breath sound, feel of air, assess the breathing for 10 seconds. Not breathing, start CPR. There is no more B, only A, airway. Then if no breathing, start CPR. And CPR will be 30 chest compression to 2 respiratory, until 2 ventilation, until the patient will be on the vibrator or the ventilator. So the chest compression will be 30 to 2 until she will be on a ventilator, so it will be out of this criteria. It will be 10 to 10, or we will review this later. But the chest compression by you will be what? 30 to 2. Until the patient will be ventilated, it's not your problem. After that will be according to the ventilator, 100 to 10. So, chest compression, and you should do the chest compression in a good way. You should put the woman on a hard surface to give effective compression, and the compression should be third of the chest diameter, 1/3, to give effective compression. You should compress the chest 1/3 of the chest diameter. So mouth to mouth only if you have no ventilation or ambu bagging. Minimize interruption and start the chest compression. The chest compression have a criteria. The rate is 100 per minute and the ratio is 30 to 2. So both are exam question. Your rhythm or your rate is 100 compression per minute. The ratio 30 compression to 2 ventilation. Okay? After that, you will until the defibrillator come. If the assessment came pulseless, no pulse, pulseless activity, asystole or no pulse, you will continue the CPR. You have ventricular fibrillation or VTAC, you will give a shock. This is the old guideline. Pulseless electrical activity, continue the CPR for 2 minutes. Shockable rhythm, which is the ventricular fibrillation or the VTAC, ventricular tachycardia, give a shock. And after the shock, continue CPR for 2 minutes. If you proceed 2 cycles, means 4 minutes, you will go for the pre-mortem cesarean section. You will start in 4 and finish in 5. Why? For the mother life, not for the baby. You are seeking the mother life. So within 4 minutes, if the woman is not responding, start the pre-mortem cesarean section. Why? It will improve the woman resuscitation. I am not thinking about the baby at all. You should call pediatrician to have the baby if more than 21 weeks, and after that, you will do the pre-mortem cesarean section on the collapsed scene by a scalpel, by 2 clamps, and a stitch. So just open and deliver the baby. A scalpel, 2 clamps to remove the baby and release the aortocaval compression, and after that you will transfer the woman to theater after effective CPR. A very important flow chart for the exam. After that, correct the causes of hypoglycemia, and again they forget about the causes of collapse or the causes of shock, and they forget about the hypoglycemia. Okay, clear? Any problem in the maternal collapse? It's a new guideline, and you will find a lot of questions in the exam. The book Q already I did it in the record in the YouTube channel, so I will go fast in it. The POP Q actually is a toy to play with it in the exam. You have 3 points in the anterior wall and 3 points on the posterior wall and 3 points on the perineum. The anterior wall, I told you before, I was in Leeds University, and one of the consultants gives me a jam jar and told me to teach the student the pop cube. Then I looked for the jam jar and I said, this is the hymen. And I will put 1 point here and 1 point here. This is the anterior wall and this is the cuff or the vagina after removing the uterus. This is the posterior wall. So A anteriorly and A posteriorly for PA. Point A in the anterior wall and point B from the posterior wall. Both are 3 centimeters from the hymen. The remaining part is point P in the anterior wall and point P in the posterior wall. This is called the POP-Q quantification system. So 3 centimeters A anteriorly in the anterior wall and 3 centimeters from the hymen A posteriorly in the posterior wall. The remaining part of the hymen of the vagina will be point P anteriorly and point P posteriorly. Okay, this is to put the point on the vagina, and this is the cuff because the cervix is removed. So no Douglas pouch, no Douglas pouch. In post-hysterectomy, so this is point C is there and point D is not there. Let's go back again to the staging. This is the RSOG guideline. This is point A, 3 centimeters anteriorly in the anterior wall and higher than the hymen by 3 centimeters. So this is the hymen, and I will put point here, which is point A anteriorly 3 centimeters from the hymen. And the same, point P anterior, point A posteriorly 3 centimeters from the hymen. The remaining part will be point B anteriorly and point B posteriorly. C for the cervix and D for the Douglas pouch. If you remove the uterus, so C for the cuff. So the anterior wall have 3 points, the posterior wall have 3 points, and the genital hiatus, which is the opening from the urethra till, from the anterior fourchette till the end of the vagina. This is the genital hiatus. The perineum from the end of the vagina until the end of the anus, and the total vaginal length, which from the hymen till the last point of the total vaginal length. These are the points which you will classify. You will find this in the last revision of February 2020. I will just go fast in it. If you're still having a hazy point, I will clarify it. So you have 9 points to comment on it on the POP-Q system. 3 anterior, 3 posterior, and the 3 for the genital hiatus, perineum, and total vaginal length. These are 9 points. On another way, he can gives you like this, figures. The figures will be point A anteriorly. What's the normal position?
3 centimeters from the external urethral
Minus 3.
Minus 3. 3 centimeters from the hymen, so minus 3. Point B anteriorly. More than minus 3, so minus 4, 5, or 6. Cuff or the cervix at minus 7 or minus 8. This is a normal position. Genital hiatus 2 to 3 or 4 centimeters, 2 to 3 centimeters. The opening of the genital hiatus. Perineal body also about 2 to 3 or 4 centimeters. The perineal body from the end of the perineum here.
Posterior forash.
Okay, the perineal body of the vagina up to the end of, or up to the anus. This is called the perineal body. Here, this is the perineal body. It's about 3 to 4 centimeters. And the total vaginal length, say it is 8 centimeters. So 4 centimeters, this will be not by minus, not by plus. The dimension of the genital hiatus, 2 to 3, perineal body, 3 to 4, and the total vaginal length, 8 centimeters. The posterior wall, the same. Posterior wall, Point A, it will be at the level of -3 to be normal. Point B higher than -3, -4, 5, 6, and point D will be at -7 or -8. This is a normal position for the POP-Q. If prolapsed, you will justify according to the stages. Let's go for the stages. Stage 1, everything is placed or descends to 2 centimeters below the level of total vaginal length. So from -8 to -6. This is called stage 0. Everything in place or till the level of -6. Total vaginal length -2. So this is stage 0. Stage 1 below from -6 until higher than the stage 2, which is 1 centimeter around the hymen, above or below. So stage 1 between this, from -1 and -6. Stage 2, -1 to +1. More than 1 centimeter, stage 3. Total vaginal length is outside stage 4. Let's go for a chart. Everything is placed or until -6, which is the total vaginal length, -2 centimeter. Here is -8, and here is -6. Here is the total vaginal length, and here is total vaginal length -2 centimeter. If this came here, so stage 0, no treatment. Okay? Stage 1, from here, -1 to -6, to make it easier. Stage 2 is the most important one, from -1 to +1. Stage 3, from +1, more than +1, until +6. Stage 4, everything is outside, from +6 to +8. All the total vaginal length is prolapsed, or total vaginal length -2, which is the +6. Everything above the hymen will be minus, everything below the hymen will be plus. Okay? Again, stage 0, everything in place or until the level of -6, which is the total vaginal level length -2 centimeters. Okay? Voice is not clear. Can anybody confirm?
Clear, sir, clear.
Okay, so
No, it's okay.
Okay. So your connection, please. The problem in your connection, Dr. Taher. I'm speaking a lot, so I'm afraid that you are not hearing me. So stage 0, everything in place or at the level of -6, which is total vaginal length -2. Stage 1, from this level, which the criteria is not met, which is -6, until higher than -1. -1 to +1, so stage 2. -1 is included here. And +1 is included here. So stage 2 is the secret. Why? Above this level of stage 2, pelvic floor muscle exercise can give a benefit. Below this, no pelvic floor muscle exercise. Because if you contract the pelvis here, you will push the uterus outside. So stage 1 and stage 2 pelvic floor muscle training is important. After that, it's nonsense. You will do contraction and you will push the uterus outside. So that's I like stage 2. Why? Because 1 centimeter above and below. This is the secret, actually, of all the if you forget the POP-Q, remember stage 2. -1 and +1, stage 2. Higher than this, stage 1, up to -6. Lower than this, stage 3. Completely outside, more than +6, it will be stage 4. Again, no prolapse, everything in place or stage 0. Higher than -1, stage 1. Between -1 and +1, stage 2. More than +1, stage 3. Complete prosodengia, everything is outside. So from +6 to +8. Again, this is a mock exam. So The exam question can come like this or like this. This is the symphysis pubis, and this is the anterior wall, and this is the posterior wall. What is this? Point A, at what level? +2 or +3. So it is prolapsed. It should be here. Point A and B should be here. Okay? So it is prolapsed for +3. And point A and B anterior also prolapsed. So this is called anterior wall prolapse. Why? Because point C is higher than -1. It's stage 1. And point B is about 3 or higher than -3. So it's no prolapse. If point B higher than -3, this will be no prolapse. If this point, this is also an exam tricks here. If these points are higher or equal to -3, so no prolapse, stays 0. Or the C or D came from -8 to -6. All this is stage 0. If point B, point A, point B all descend then this level, -3 up to -1, so stage 1. -1 itself and +1, stage 2. Okay? So, in this question, he will tell you what is the main problem. It's anterior wall. All prolapsed outside. And this question, it's posterior wall. The anterior wall is in place. So, the treatment here will be posterior repair because point B anterior and point B posterior and point A posteriorly both prolapsed. And here, the anterior wall prolapsed, so it will be anterior repair. So the number can come like this by number because you know the normal position. Point A, normal. Point B, normal. Point C or the C or the cuff after hysterectomy, normal. Genital hiatus is little bit big because the prolapsed part dilated the opening. Perineal body is short because dilatation of the genital hiatus. The total vaginal length is normal, 8 cm. The posterior wall prolapsed, +2, so stage 2. +5, this is stage 2, sorry, stage 3. +1 is stage 2. So stage 3, and no Douglas pouch. So the posterior wall is stage 3 prolapsed. More than +6 will be stage 4. So in the question here, it will be stage 3 posterior wall prolapse. No pessary will give benefit here. Because, no pelvic floor muscle contraction. Pessary is a treatment. For 3 and 4, pessary is a treatment. All kind of prolapse can give a pessary, but the pelvic floor muscle exercise is valid until stage 2 here, until this limit. The pelvic will contract and give you a benefit. In stage 3, nothing. Does this make sense? Are you happy till now?
Yes.
Okay. So, let's...
More than happy, sir.
Yes? Can you repeat? If you want to ask, please repeat. I didn't hear.
We are more than happy.
Okay, I am very happy for that. This is also to highlight another, again, the POP-Q question. This is the normal position, and this is the one you will have in the exam. -3, more than -3, -6, -8, -3, -3, prolapsed to +3, +6, +8, +6, +3. So number or figure, I will get these marks. Okay? Let's do just a question. Let's see how to answer in the exam. A patient presents with symptoms of a bulge in her vagina. On examination, the pelvic organ or the POP-Q quantification system scores A at 0. This is what?
This is stage 2.
Excellent.
No prolapse.
So stage
0.
Stage what?
Stage 2.
Stage 2, anterior wall prolapse.
And B at 0. Stage 2. C is high. D is high. B, AP at -2. So this is what?
High.
1.
1.
Stage 1.
So this is stage 1. Posterior wall. Vaginal length is fine. Genital hiatus is little bit normal. Perineal body is little bit normal. The patient wants her prolapse to be treated surgery. So this is mainly what?
Anterior walls.
Anterior wall.
Stage 2 prolapse and anterior repair.
Excellent. So this patient need a surgery. So stage 2 anterior wall prolapse and anterior repair. This one. Stage 2 anterior wall prolapse and anterior repair will be answered. This is how to answer. With number, with figure, with anything, I will get this mark in the exam.
Stage 2.
So, Hany, for this stage 2, it cannot be very only.
Pessary is an option. Pelvic floor muscle is an option, but the patient wants surgery. Until stage 2, pelvic floor muscle is effective. Why? Because it is at the level of pelvic floor. After that, pessary or surgery. So pelvic floor muscle is an option. Surgery is an option. Pessary is an option. Counseling. If the woman told you, I need surgery, so this will be the answer. Again, this is a trick. But the vice versa. You see, A at -2, B, A at -2. This is stage 1.
Stage 1.
Anterior. Posterior, stage 2. So,
yes.
Stage 2, rectocele. And the answer will be posterior repair if she wants a surgical treatment. But pelvic floor is valid in stage 1 and stage 2. After that, no pelvic floor. In stage 3, if you contract the pelvic floor, you will push the prolapsed part outside. So no pelvic floor muscle training or pelvic floor muscle exercise in this. If you need more details, just go for the YouTube channel. You will find it in a very specialized way. I spent a lot of time because I am losing time now and I want to give you all my target. Urodynamic also an easy marks in the exam. It is not an issue. I will not leave marks. I will not lose marks here. The woman come to my clinic in the urogyne department in Southmead Hospital, NHS Trust in Preston. And she told me I have a problem in my urine. I told her, okay, I will tell her to put or sit in a special commode and to pass urine in a special apparatus called the uroflowmetry, and I will collect it in a special machine. It will give me the uroflowmeter. And after that, I will put 2 catheters, one in the bladder and one in the vagina or in the anal canal. Why? This one will give me the intra-abdominal pressure, and this one will give me the intravesical pressure. And I will have 2 charts. Subtraction of this chart will give me the detrosal pressure. Simply, this is the cystometry or the urodynamic. How to interpret this chart? It's a very easy mark. 1 catheter in the bladder, 1 catheter in the rectum or the vagina. This one will give me the B abdominal and this one will give me the B vesical. I will subtract both of them to get the detrosal pressure. Simply, if you find detrosal pressure is moving, it will be detrosal overactivity. I will give you the clues. After you put the catheter, tell the woman to cough. The vaginal catheter or the intra-abdominal pressure will move, and this pressure will be transmitted to the bladder. The intravesical pressure will move, but the detrosal pressure is stable. This is the filling phase. I will tell the woman to cough to test my catheter only. So the intra-abdominal pressure will move, the intravesical pressure will move, but no pressure in the detrosal muscle. The detrosal muscle is not contracting. It is relaxed and no leak. So this is normal response. If the woman have detrosal muscle simply contraction, so it is detrosal overactivity. Why? It will be transmitted to the intravesical pressure and no abdominal pressure. I am not coughing. I am leaking only because of the detrosal muscle contraction. I will go back again. If I coughed, so I am coughing here, the intra-abdominal pressure will be high. It will be transmitted here, but the detrosal is relaxed. That's why it's a normal response if no leak. If there is a leak with cough, this is a clinical response. A stress urinary incontinence need no dynamic, need no neurodynamic, except for a special indication, which when to do stress urinary incontinence, to do urodynamic, because this is also an exam question. Anybody knows what is the indication or when urodynamic will be indicated? Recurrent surgery, excellent. Kausar, what else?
In a failed SUI surgery.
SUI previously anterior prolapse. Mix or interior prolapse.
All of you are excellent. Excellent. Actually, I was thinking you will not answer. Excellent. A recurrent surgery, apical or anterior wall prolapse, and you are unsure about the diagnosis. These are the three indications to do urodynamic. If you find out or anterior wall prolapse, excellent. Yes, more than excellent. So a stress urinary incontinence is a clinical diagnosis. You will do urodynamic only if you have one of the indications. If you find the detrosal muscle contracting, so detrosal overactivity. If you have urodynamic, you will change the diagnosis. Urodynamic stress incontinence or detrosal overactivity, not overactive bladder. Overactive bladder is a clinical diagnosis, symptoms and signs. Confirmed by urodynamic, it will be detrosal overactivity. Simply, look here. Detrosal muscle contract, so it is detrosal overactivity. No contraction, so normal response, a clinical diagnosis. Sorry.
There's no camera. There's no slides being shared.
Just a second. I pressed the go to meeting. Sorry. I will drink water. Just a second, please. Okay. Now you can see my slide.
Yes.
Yes, clear.
So the question will come like here. A detrosal muscle contract, give you a pressure intravesical, so detrosal overactivity. Stress urinary incontinence is a clinical diagnosis. Cough intra-abdominal transmitted to the intravesical. Detrosal muscle is stable, no contraction. Okay? If there is a leak, so a urodynamic stress incontinence. All these are exam questions. This is the voiding phase. This is normal. I am the one contracting my bladder, the one transmitting this pressure to the catheter in the urethra or in the bladder. I am the one doing the urofrometry or doing the urine. So the filling phase, voiding phase, detrosal overactivity, you will have contraction in the detrosal muscle. Clinical diagnosis, the vaginal catheter is moving, the abdominal pressure is moving, transmitted to the intravesical catheter, but the detrosal muscle is stable, so very easy marks in the exam. If you want to know more, just review the last revision. on the YouTube channel.
So can you repeat the indications for this urodynamic study? You said 3 indications.
Yes, Nikita. Urodynamic should be done in stress urinary incontinence because of stress urinary incontinence is a clinical diagnosis. You don't need urodynamics to confirm stress urinary incontinence unless you have a mixed incontinence and you are unclear about the diagnosis, or a woman have surgery before for stress urinary incontinence and she need another surgery, so recurrence, or apical and anterior wall prolapse plus stress urinary incontinence. Does this make sense? No, Samira. For stage 2, pelvic floor muscle exercise will give you a benefit because the prolapse will be at the level of the pelvic floor. Stage 3 and 4, actually the pelvic floor muscle will push the prolapsed part outside. So pelvic floor muscle is valuable only in stage 1 and 2. Okay? Okay. Let's move. Okay. I have a lot of tricks, so let's give you all the tricks. Postmenopausal ovarian cyst is a critical chart for the exam. When to follow up, when to remove, when to treat, when to do CT and refer for MDT. A postmenopausal ovarian cyst of 1 centimeter only, because a lot of you thinking about 5 in the postmenopausal. It's 1 centimeter cyst can give a problem in a postmenopausal woman. So 1 centimeter cyst need to be investigated in a postmenopausal cyst. Take care. A postmenopausal ovarian cyst with 1 centimeter or more need to be investigated. What will be the investigation? Transvaginal ultrasound plus the risk of malignancy index, the cancer antigen 125. If it is less than 20, so low risk of malignancy. More than 200 or less than 200. Less than 200, so you will follow up what I will tell you. More than 200, CT, because a high risk of malignancy. So the next question, exam question, will do a CT abdomen and pelvis. Then refer to the multidisciplinary team. Less than 200, the RMI. This is also another question. In the NHS or in the RCG, which is the one responsible for triaging or managing patient? It's RMR. You are triaging here by RMR. You are not using IOTA for triaging and managing patients in UK. So the RMI is the one responsible for triaging and managing patient of postmenopausal ovarian cyst in UK. If it is less than 200, so you should have all this criteria: asymptomatic, simple, less than 5, unilocular and unilateral. If any one of this criteria is broken, so bilateral salpingioophractomy. There is no unilateral in postmenopausal woman. Bilateral salpingioophractomy. If the cyst is symptomatic, non-simple, more than 5, multilocular or bilateral, any one, 1 centimeter, risk of malignancy index less than 200, symptomatic, painful, non-simple, multilocular, bilateral, any of these, bilateral salpingioophractomy. Asymptomatic cyst should be less than 5, unilocular, unilateral, simple cyst clear. To do what? To repeat the scan after 4 to 6 years, 4 to 6 months. What? This is conservative treatment. The conservative treatment, to repeat the assessment again. Ultrasound and cancer antigen 125. Resolve, discharge. Increased, remove. No voice? Voice is clear?
So in between,
between
it was not there.
Okay, I will repeat what I said. I will repeat what I said again. No problem. If you have all these criteria are met, less than 5, asymptomatic, simple cyst, unilocular and unilateral. This the criteria of repeating the ultrasound. Otherwise, I will do surgery. When to repeat? 4 to 6 months. I will repeat what? I will repeat the assessment again. The ultrasound and the transvaginal ultrasound and the cancer antigen 125. If the cyst resolves, discharge. Increased, change it in the feature, remove. But persistent, unchanged for 1 year, individualize the treatment. So the woman have asymptomatic cyst, simple cyst, unilateral, unilocular for 1 year, ask her wishes. She would like to continue or discharge, or she would like to remove a surgery. So individualize the treatment, either discharge or treat the woman with bilateral salpingo. This is almost coming here. Either the conservative measures for 1 year to individualize the woman wishes, either discharge or remove, or any change in the criteria of the cyst you will remove, or a high risk of malignancy, CT will be the answer after the RMI 200 or more. Then refer to the multidisciplinary team, will discuss and see what will the woman best choice will give you the first treatment from the first decision. She will get a multidisciplinary team review of high risk of malignancy, so staging laparotomy, or low risk of malignancy, she can do a pelvic clearance. Okay? Any question about this chart? A very critical chart for the exam. Endometrial hyperplasia. Again, a very critical chart for the exam. The cut value or the gold standard is transvaginal ultrasound, and the cut value in a perimenopausal woman is 7. Postmenopausal woman is 4. With tamoxifen is 11. 4, 7, and 11. In perimenopausal and PCO, the cut value is 7 millimeter. Postmenopausal is 4 millimeter. Endometrial hyperplasia or woman with high risk with taking tamoxifen, because tamoxifen increasing the risk of endometrial hyperplasia and polyps, so the cut value is 11. Transvaginal ultrasound is the gold standard. What you will do for management of endometrial hyperplasia? The new guideline says that either to be endometrial hyperplasia without atypia or with atypia. Without atypia, so either to wait and see, let the nature take itself. A lot of women refuse treatment, so wait and see for how many? For 1 year, then start the treatment. So observation or treatment, the first line is Mirena and the second line is oral progesterone. If the woman got this treatment in endometrial hyperplasia without atypia, so you will follow up here by endometrial biopsy every 6 months. If the woman have atypical hyperplasia, the definitive treatment is total hysterectomy with bilateral salpingo-oophorectomy. There is no conservative treatment unless she is young. Again, the definitive treatment is total abdominal hysterectomy and bilateral salpingo-oophorectomy. Why? Because the risk of concomitant cancer and the risk of ovarian cancer. So this is the definitive treatment. If there is fertility issue, a young woman need to have a child, or surgery is contraindicated, I will think about the conservative treatment, which will be Mirena or oral progesterone, and follow up every 3 months if the woman have abnormal hyperplasia. All these are exam questions. If you lose, you will concentrate here, you will lose a lot of marks. So you put a Mirena or you treat a woman with progesterone. The follow-up will be every 6 months if the woman have endometrial hyperplasia without atypia. Every 3 months if the woman have atypical endometrial hyperplasia. Regression, continue follow up. Keep the Mirena for 5 years, oral progesterone for 6 months, total abdominal hysterectomy or bilateral salpingiorectomy if the woman have a bleeding. If the woman have endometrial hyperplasia without atypia or endometrial hyperplasia only without atypia, and the BMI less than 35 and treated by Mirena, not by oral progesterone, so you will do 2 endometrial biopsy. If both negative 6 months apart, then discharge. But if the woman is obese or treated by progesterone, you will do 2 consecutive negative 6 months apart and annual thereafter. Why? Because high risk of recurrence. Obesity, HRT, tamoxifen is a risk factor. So never discharge here. BMI 35 or more annually thereafter. Treated by progesterone, not by Mirena, annually thereafter. All these are exam tricks. Atypical endometrial hyperplasia, you will follow up here every 3 months. If she got negative, 2 consecutive negative endometrial biopsies 3 months apart, then annual thereafter until what? Until removing the uterus. Because the definitive treatment is total abdominal hysterectomy and bilateral salpingiorectomy. I will speak here for this woman which have atypical hyperplasia and have Mirena or progesterone for 3 months and she got only 1 negative and her age is 39 or 40, I will refer here for fertility specialist. If she got 1 negative result, then she will have a baby, fertility specialist referral, continue her family and remove the uterus. If it is persistent, endometrial hyperplasia without atypia, and you didn't start a treatment, she choose nothing, wait and see, start the treatment after 1 year. If she is persistent after treatment for 1 year, so total abdominal hysterectomy. This is a trick here. If the woman start a treatment even with endometrial hyperplasia without atypia, persistent for 1 year with the treatment, this is indication to remove her uterus. So start the treatment. If observation failed, advise total abdominal hysterectomy plus bilateral salpingiorectomy if persistence for 1 year after medical treatment. Endometrial hyperplasia, so definitely. I have a trick here. If the woman have atypical hyperplasia and you put a Mirena and you find after 1 year endometrial hyperplasia without atypia, what you will do? Excellent. Why? Because if the woman, even she is regressed, but she's still persistent endometrial hyperplasia, persistent for 1 year. Even she regressed from atypical to hyperplasia only without atypia, but persistent for 1 year. So this is an RCOG trick to see what you are thinking about. Okay? So endometrial hyperplasia without atypia, with a treatment for 1 year, even it is step down from atypical, but persistent hyperplasia removes the uterus. Progressed, so you will be in the cancer center. Review the treatment, atypical hyperplasia removed, endometrial cancer managed according to the cancer guideline. Arrange the follow-up review after 6 months or after 6 weeks or discharge on marriage according to the unit protocol if you have endometrial cancer. These are the tricks. Actually, this notes is very important. That's why I put it in the next slide. The risk factors: obesity, HRT, tamoxifen. Reserve the ovary. Even if you have atypical hyperplasia in a young woman, see this in the guideline. Uterine preservation, you remove the uterus only and leave the ovary, even with atypical hyperplasia in young woman. Individualize the treatment. Okay, read this in the guideline. All these notes are very important. Just have a look on it. Let's do a mock exam or a mini mock on the endometrial hyperplasia. How it will come in the exam. A lot of options. I will not read.
Dr. Hany, can you please repeat the follow-up of atypical hyperplasia if the patient wants to get pregnant?
If the
when to give her a chance for two samples to be negative and when to be only one chance?
I will highlight this in the mock exam. If the woman is young and she have a fertility issue, 35 years or 39 years, and she want to get a pregnancy, so I will treat her by the conservative treatment, Mirena or oral progesterone, and I will follow up her every 3 months by endometrial biopsy. If she got only one negative, so I will refer her to fertility specialist to have a baby and complete the family. After that, if she completes the family, I will remove the uterus. The follow-up normally every 3 months, endometrial biopsy. Okay? The other trick...
I mean, yeah.
The other trick of endometrial
because you said one
treated by progesterone or the BMI more than 35. You will not discharge here after 2 negative. You will continue annually. Okay? Let's see the mock exam. I all the tricks in the mock exam. See this lady.
Thank you.
Can you read, please? I lost my voice. I'm speaking for 5 hours now. Can you read, please?
A 55-year-old lady presents with postmenopausal bleeding. The PPL biopsy shows endometrial hyperplasia without atypia. She declines to have a coil.
So, what will be the answer?
Then we'll give her oral progesterone.
Oral progesterone.
Excellent.
Oral is conservative.
Okay. Question number 2.
A 43-year-old para-2 lady has a BMI of 46. She complains of menorrhagia and the PPL biopsy shows endometrial hyperplasia without atypia. She had Mirena coil inserted 2 years ago, but the symptoms have recurred. Then, if continuous AUB is there, we go for surgery.
Excellent.
THBSO.
You will remove the ovary or you will leave the ovary?
We will remove it, sir.
Excellent. You will leave it.
Leave the ovary.
You will leave it. This is the trick. I will go for the endometrial guideline, endometrial hyperplasia guideline now. And I will tell you to individualize the treatment. If the woman age is young, even endometrial hyperplasia with atypia, I will leave the ovary. I will not remove it. You see here?
Sorry, what's the age limit for removing the ovary in this case?
I will highlight it within a second. I know this by heart, just I want to tell you. For perimenopausal woman, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy, you will remove the uterus and the tubes, should be considered as it may reduce the risk of ovarian pregnancy. In what? In atypical hyperplasia. Not only hyperplasia without atypical. Atypical hyperplasia in perimenopausal woman, I will leave the ovary. I will protect her heart, protect her from menopausal symptoms, protect her from osteoporosis. It's a new concept till the age of 60. Does this make sense? This is the guideline. This is the evidence-based answer. So come back again with me for the crash course. A total laparoscopic hysterectomy plus conservation of the ovary. Why? A perimenopausal woman. Remember, you can individualize the treatment. Okay? Remove the uterus remove the tube, but please remember to leave the ovary. The ovary will protect her heart from cardiovascular stroke before the age of 60, the HRT guideline. The ovary will protect her bone from osteoporosis. The ovary will protect her from menopausal symptoms. Perimenopausal woman, remember to leave the ovary. Question number 3.
A 42-year-old para 3 woman is diagnosed with endometrial hyperplasia with atypia. She had oral progesterone therapy. Her follow-up endometrial pupil biopsy at 12 months shows endometrial hyperplasia without atypia. So it is continuing for 12 months. So we go with TAH surgery. So we conserve the ovaries.
Excellent. Now you are awake. So I will remove the uterus, the tube, and I will leave the ovary in place. Question number 4.
A 49-year-old lady complained of menorrhagia and was found to have endometrial hyperplasia without atypia 2 years ago. She had Mirena coil at the same time. She had 2 pupil biopsies 6 months apart and they were normal. So she will be discharged.
Is a woman
discharged?
A woman
She'll be discharged and she'll continue to keep the Mirena.
Okay, so is not more than 35 and treated by Mirena, not by progesterone. So I will discharge here after 2 consecutive negative biopsy. Normal, I will discharge here. If the BMI 35 or more or treated by progesterone, so I will continue annually thereafter, every year, because of the high risk of recurrence. Excellent. Another question.
A 39-year-old now complains of menorrhagia. She's found to have endometrial hyperplasia with atypia. She wants to conceive soon.
Why?
Then
why he told you this? Why?
Because we don't want to do surgery for her. We'll give her progesterone.
Excellent.
Surgical for
can take progesterone and then after 2 consecutive this negative or hyperplasia
Negative.
go for IVF. Can say her IVF.
I told you before, if the woman got 1 negative only because of her age, I will refer her for the fertility specialist to have a baby. Okay? Remember this, please. So I will give her oral progesterone and endometrial surveillance 3 months. If she got, this is the RCOG trick. If she got 1 negative sample only, I will refer her to the fertility specialist. Then, after she complete her family, I will remove her uterus.
So for this patient, Hany, we have to give only oral progesterone, right?
Because
there's no role of Mirena here.
He wants to conceive soon. I cannot put Mirena in this woman. Okay?
And progesterone for 6 months, sir?
And progesterone for 6 months, but I will repeat the endometrial biopsy after 3 months because atypical hyperplasia. Okay? My last
but doctor, if she is after 6 months of
she will need
the
ovarian hyperstimulation syndrome. Actually, the RCOG likes the ovarian hyperstimulation guideline. Actually, they are obsessed about it. They like it so much. So you should know this by heart. I will give you the clues. History taken. How many eggs collected? Follicles. How many embryo replaced? PCO is a risk factor. Symptoms: discomfort, abdominal bloating, pain, vomiting, restlessness, reduced urine output, leg swelling, vulval swelling, edema, associated with any comorbidities. So, history and symptoms are very important. Examination, general examination, abdominal and respiratory. Why? Because pleural effusion, extravasation will cause respiratory distress and respiratory problem. So general examination, abdominal examination for ascites and respiratory. Investigation, a full blood count, hematocrit, C-reactive protein. I am going for the hematocrit because it will make a difference. It will classify moderate, severe, or critical. Urea and electrolyte, C-reactive protein, osmolarity, liver function, coagulation profile, beta SCG. If she got pregnant in an ovarian hyperstimulation syndrome, she will be at a risk of failure, a risk of VTE, a risk of abortion, a risk of high risk pregnancy, and giving low molecular weight heparin in the first trimester. What is other indicated? Arterial blood gas, D-dimer, ECG, chest X-ray, and CTPA if the woman got pulmonary embolism. What else you need? You remember in this, the classification, the category, mild, moderate, severe, critical. Mild, just a bloating, abdominal pain, and the ovary less than 8. Moderate, between the ovarian volume, the ovarian size, 8 to 12 centimeter, the ovarian volume, not a cyst, the ovarian size again, centimeter cubic. Okay, 8 to 12 will be moderate. Severe, more than this, or the hematocrit. So clinical ascites, oliguria, hematocrit will come in the exam. Critical hematocrit will come in the exam. So severe ovarian hyperstimulation, clinical ascites, oliguria, hematocrit, hyponatremia, hyposmolarity, hyperkalemia, electrolyte imbalance, hypoproteinemia, and ovarian size more than 12. So classify the question to manage it. Mild and moderate can be treated in outpatient with drink water up to thirst or guided by thirst. If the woman cannot tolerate the oral fluid, she need admission. Once she need admission, she need low molecular weight heparin. Outpatient, she can use elastic stocking and come every 2 to 3 days or every other days to repeat the assessment and repeat the investigation. A critical, tense ascites, hematocrit level more than 0.55. Oliguria, thromboembolism or acute respiratory syndrome. Classify and know the stage to know the management. Non-steroidal anti-inflammatory is a killer. So ibuprofen is contraindicated in ovarian hyperstimulation syndrome. Indication for paracentesis is an arthrogetrix. What is the indication for paracentesis? Anybody knows?
Severe ascites, urine passing breath.
Even after
Oliguria,
radiotherapy.
Wow.
Oliguria.
Wow. More than excellent. I thought that
Persisting.
Actually, you answered. Indication of paracentesis, you have 3 indications for paracentesis. Severe abdominal distension or abdomen secondary to ascites. Shortness of breath or respiratory center, respiratory depression or respiratory compromise due to ascites, breathlessness. And the third one, oliguria despite of hydration and volume replacement. And this one always coming in the exam. So you are correcting the woman, you are giving IV fluid, and still she have oliguria. So the answer will be paracentesis. Okay? How can paracentesis done? It can be done under ultrasound guided either to be abdominal or vaginal, and you can inject intravenous colloid to correct this. So how to think? What is the indication for paracentesis? This is my last message for you today. I hope you got benefit from me, and I hope I clarified a lot of issue. So this is the indication. Can be done abdominal or vaginal, and you can inject intravenous or give intravenous colloid to restore this fluid volume. Should be considered for women who have a large volume of fluid removed by paracentesis. What is the volume? The randomized control trial said that about 2,000 milliliters gave a benefit in improving the ascites and respiratory symptoms. Don't remove more than this. All the best from my heart. Wishing for you all success in this batch from Dr. Hany Taher. I wish John to join my next batch.
Thank you. Thank you so much, Dr.
Thank you so much.
Thank you very much, Dr. Hany.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Recording available?
Thank you.